the Joint Standing Committee on Health and Human Services. We'll be working on 2, 4, 6, 7 bills this morning. And this afternoon, we'll be hearing from the ambulance world about their circumstances, and we'll do a public hearing after that. We'll be hearing the bills in order this morning that they're published, numerically going up, except for 958. We need to hold that one back until about 11 o'clock or until Molly Bogart can join us with an amendment that she and the sponsor have been working on. So we'll hold 958 until 11, and as soon as Molly's back, then we can start the work on that one. If you'd like to watch us in video as well as hear us, you can go to legislature.maine.gov, look up Health and Human Services, and under that, there's a link to our YouTube channel. Everything's recorded, so you won't miss anything, and you can go back and see old sessions if you'd like. We continue to mention every day that there's likely to be some technical glitches along the way, people who can't be heard, people who can't get in. Bear with us while that happens, and we've gotten better about fixing some of those things. I've remembered to mute my phone so that I don't have to pay the $5 like Representative Perry does from yesterday. We will now go ahead and introduce the committee. Let's start with Representative Griffin. Or not.
Oh,
wait,
sorry. Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadesque.
Representative Connor.
Thank you, Mr. Chair. Good morning, everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Zager.
Good morning, everyone. Good morning, Mr. Chair. Sam Zager. I represent District 41 in Portland.
Representative Lemelin was here, so when he comes back, we'll introduce him. Here he comes. Good morning, Representative Lemelin. Your turn.
Good morning. I'm Michael Lemelin. I represent House District 88.
Sounds like your internet connection is a little flaky. That's not good because you're in the State House, right? Or on campus? Wow. So Representative Lemelin, we didn't hear all that. That's just by way of heads up. So we may need to have you go to no picture if the wireless is that bad where you are. But anyway, Representative Perry.
Good morning. I'm Ann Perry. I represent House District 140. That includes the communities of Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Good morning, and thanks to all who are joining us here today. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott and parts of Kittery and South Berwick.
And I'm Ned Claxton. I have the honor of representing Senate District 20, which includes Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. We're joined by the staff that makes a lot of this possible. Ms. Broom.
Hi, I'm Anna Broom. I'm one of the legislative analysts for the Health and Human Services Committee, and I work in the Nonpartisan Office of Policy and Legal Analysis.
And Ms. Withy.
Good morning. My name is Carrie Withy. I'm the clerk for the Health and Human Services Committee. If you need any assistance during the hearing, please, the work session, please email me at hhs@legislature.maine.gov.
She's the chief fixer for getting people in when they're having technical problems. So keep that address handy. I wanted to ask a question of Anna before we start. Is there a definition in rules or statute for community mental health service providers? That covers a range of folks, or is that just a term that is not at this point defined, either in statute or rules?
I don't know the answer to that, but I
Yeah.
could have a look in a moment or two.
Yeah, no, when you get a chance. We've just
Okay.
been joined by Representative Stover. Would you like to say good morning?
Thank you, Senator Claxton. Good morning, everyone. My name is Holly Stover. I am the House Representative for District 89, including Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol. Thank you.
And the bill we're supposed to be working is 432, but I also don't see Representative Madigan. And I don't know if she's not expected. So why don't we start then, now that I'll take back what I said earlier. Let's start with 783.
Let me just get the right one here. All right, share my screen. Hopefully you can all see that. This is LD 783, an act regarding the membership of the Sexual Assault Forensic Examiner Advisory Board. This bill adds to the membership of that board an additional sexual assault nurse examiner and one representative of law enforcement. The bill also clarifies that one member is a representative from a sexual assault support centre and changes the membership representing the State Board of Nursing to a member representing a school of nursing. And the duties of what they do there are at the bottom. You heard during the public testimony that the State Board of Nursing has never participated, so they're proposing to replace with a representative of School of Nursing. One of the two public seats that is required on that board is currently filled by someone with law enforcement, and they would like to include law enforcement specifically, and then have two full public members. The department sent in their support, and we haven't yet received a fiscal impact statement from OFPR, but I believe that you heard at the public hearing that all those folks are volunteers, so there shouldn't be one. Obviously, I'm not the one that decides that, but that's my understanding.
So does that prompt any questions from the committee in response to that analysis? Thank you, Anna. I don't see any. Anybody want to, Representative Perry was first.
Yes, I would just like to move ought to pass as amended if it needs it.
And I'll second that.
We don't need the amended part because we haven't got a fiscal note yet. So we'll
Right,
just
if
make it
one-
ought.
Right, if one comes, we would change it to ought to pass as amended, but I don't really expect one. So.
One of the few. Ought to pass is the motion on the floor. It's been seconded. Is there any discussion?
What
of
about
this?
the issues up from the?
I heard Senator Moore.
Okay, okay, then let's do it. Thank you, Senator Claxton. I'm wondering if we do want to go ahead and include the replace, instead of State Board of Nursing, have it replaced with School of Nursing as suggested.
No, that's
And then also.
that's how it's written. That's how the bill is
Oh.
written.
I think that's.
Okay.
So I think all three of the things that were referenced are
Yeah.
Are there.
are contained in the bill.
Okay.
Sorry, I wasn't very
misunderstood.
clear. I wasn't very clear,
misunderstood.
Senator. I'm sorry.
No problem. Thank you. I misunderstood.
All right. So there's a motion on the floor, ought to pass, and it's been seconded. Any further discussion, questions? Then Ms. Withy, it's your turn to run the vote.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry,
Yes,
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan, Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Thank you. So now we'll move on. As I said, we need to skip 9:58 until participants are here that we need, and we can go to 10:64.
64. So this is an act to advance palliative care utilization in the state. I'm going to skip over the first paragraph of the summary because that's the bill as it was originally drafted. So you received an amendment at the public hearing, and it removed section 1 of the bill, which was the section that was related to standardization standardization of palliative care and educational materials. It keeps the section that's requiring reimbursement under main care. And that section also requires the department to adopt rules. It amends the bill to require the department to use the National Clinical Practice Guidelines for Quality Palliative Care from the National Coalition for Hospice and Palliative Care, try to say that quickly, to advise development of the rule. It also requires the department to periodically convene a stakeholder group representing palliative care and the Quality of Life Advisory Committee and the Home Health and Hospice Alliance of Maine to advise on educational documents. So you heard during the public hearing, the proponents are looking for a team-based interdisciplinary approach corresponding main care reimbursement. They're looking for a sustainable rate and a way to expand access. And you heard that not all hospitals have palliative care teams. The amendment was requested by the sponsor, Northern Light, and the Home Care and Hospice Alliance of Maine. And the Cancer Society is also looking for additional language that all main care enrollees for whom palliative care is appropriate according to evidence-based guidelines must have access to these services. You heard from the department that, or rather you received testimony from the department, that the department cover most of the or main care covers most of the services that would fall under palliative care without identifying the services specifically as palliative care, except for spiritual services which are not eligible for federal match. The department has met with stakeholders about a team-based community palliative care options and believe that there are merits to a bundled alternative payment model, and they could look at other state models. But this project should be led by the value-based purchasing unit, which you heard from with a presentation, and they need realistic timeframes to accomplish this. So there are some drafting issues with the amendment specifically that I've gone back and forth with one of the advocates. So you can't put private organizations in statutes or even in a resolve. So we can't cite the National Coalition or the Home Care and Hospice Alliance of Maine. There are some suggestions that have gone back and forth that I can move down to in a little bit. There was a suggestion of changing it just to the guidelines for use in developing the rule. I'm not sure advise is the right word, but it's still an organization which could change. The guidelines could change, the name of them could change. That's why we don't put these in statute. We do put governmental things in statute, but we don't put organizations. I mean, anything that says .org is a good clue. And so it might make more sense if you do want to go down this road, you could put some unallocated language to cite those guidelines rather than putting it in statute. And you would also need to refer to an organization representing home care and hospice providers, not to the Home Care and Hospice Alliance of Maine, if you want to move forward with that. I'm a little confused about the educational materials part. Educational requirements are no longer required in the bill, but they are still referred to for stakeholder duties. There was a clarification suggestion that I received yesterday just before I sent this, or maybe it was even after I sent it, that the clarification could be educational materials related to the rule rather than required by this section, because they're not required by this section. And there was certainly no need for rules to be included twice. You did ask for information about other states. There's a lot out there. I don't know how to put it in a way that you're looking for it. So I sent you a bunch of links, and I don't know if you had time to look at those or not, but NASHB has been doing a lot of work on palliative care. We haven't yet received a fiscal impact statement from OFPR. So this first part here was the amendment that you received at the public hearing. The first part was she was just putting in the palliative care definition so that you could see what it looked like. Just to remind you what it is, it's not, this part is not actually suggested to be in the bill because it's already in the law. So they're looking at this section 2. So this first part relates to the reimbursement, and this is the same as in the bill, that the department shall provide reimbursement under the main care program for palliative care for the entire interdisciplinary team. And then that's just highlighted to show that you would be referring to the current statute. And then rules, this is the part about the National Coalition that we can't really refer to. And then the stakeholder group. So then I'm just going to move down a little bit in case you can't figure out my shorthand. That's Lisa Harvey McPherson, is what LHM means. If you do want, this is was another suggestion to try and clean up some of the issues up here. So this subsection 1 would remain the same, with the exception of the clarification of the cross-reference. And then the second, the subsection 2 would be that the department shall adopt rules to implement this section. The rules must include, but are not limited to, reimbursement policies and quality control measures that ensure and promote high value palliative care under the main care program. You would need to skip this next sentence. And then rules adopted pursuant to this subsection are routine technical rules. And then the stakeholder group language is the department shall periodically convene a stakeholder group representing the main palliative care and quality of life advisory council, because that is in statute, and a group representing home care and hospice providers in Maine to advise on educational, what did I say? Educational materials related to the rule. And then if you do want to go down this road, then you would have unallocated language that makes reference to the National Coalition guidelines advising the department. So I hope that makes sense. I'm happy to, if you want to go down this road, I'm happy to talk you through it again, but hopefully that makes sense, that it can't go forward quite like you received it at the public hearing.
Representative Craven.
Thank you. Thank you very much, Mr. Chair. Thank you, Anna, for doing all that work. I was wondering if Candace Powell is in line, that we could have her come in to make some suggestions.
That's happening.
Thank you.
Welcome, Ms. Powell.
You're muted.
You're still muted. We had some questions of you. Were you able to hear that analysis by Anna?
I did. I was, and I have a few thoughts, but I think it's something that can easily be dealt with.
Mm-hmm. So do you want to ask specific questions, Ms. Powell, Representative Craven, or do you just want to give her a chance to respond to some of the suggestions?
Yeah, I would want her to respond to some of the suggestions. Thanks.
Sure. I don't think it's, thank you, Anna, for your work on this. I appreciate it. And your comments and suggestions and analysis certainly make a good deal of sense. As far as names of people go, do you want me to, I think I can deal with the issues in general. And if you want me to focus more specifically on one of the highlighted areas, I'd be glad to. I don't have the document right in front of me, but in regard to names of people, they can be in general. There are a lot of wonderful, experienced people in the state of Maine that can be a part of a periodic advisory group. And I think that could easily be dealt with by just saying such in the document, that those appropriate experienced home care and hospice clinicians and or the agencies that they represent could be part of that advisory council or steering committee or whatever the department calls it, to address these issues ongoing. I also think that, oh gosh, I don't have the document right in front of me, so.
So I think we'll be needing to change the language of the mandated source for guidelines
Yeah.
to something that says a nationally recognized.
Thank you. That's right, a nationally recognized document to provide guidance for quality palliative care delivery, or something very general like that. There are a couple documents out there, the practice guidelines, the national consensus document, but they're all nationally recognized as providing standards for palliative care delivery, yeah, and implementation.
And representatives of the stakeholder group could include people, anyone in the state who's currently doing palliative care.
Absolutely, it's really important, and I think I don't want to speak for anybody else for sure, but I would think those practitioners in the state that do palliative care really realize the value of bringing years of experience into a conversation such as this. So, and there are several wonderful people in the state of Maine that would be great participants for a process like this.
Okay. Does that address your questions, or you have any other more specific questions, Representative Craven?
No, thank you.
Okay, and are you comfortable with the language change around educational requirements and tying them to the revised language in the amendment?
It's fine with me. Is that good, Candace?
Could we just discuss that a little bit more? Anna, could you just share that piece with me again?
Yes, so if you can, I don't know if you can see this, Candace, but this is the way it was yesterday, where it said that department shall periodically convene a stakeholder group, to advise on educational materials, except it wouldn't say related to this section. It would say, oh, I can't make myself go up here. It would say educational materials related to the rule. And unless you want to put educational materials somewhere else in here, because there are no educational materials required in this section anymore, because that was in the original bill. But Lisa, who I do believe is also in the waiting room, she suggested at the end of the day last day, poor Lisa, went backward and forward with her. I just kept saying no, and she kept trying to come up with new things, is educational materials related to the rule. So that's what it would say down here.
So that educational piece is rule specific. Is that what I'm hearing?
Yes, unless you want to put, unless the committee wants to put educational materials somewhere else in here, and it's not there right now.
Yes, and I'll just add this reflection on that question. Educational materials in regard to public education, patient education, family education are also very important. I don't know if that's a bridge too far for this particular bill, or if that belongs to the provider organizations solely, but I would be remiss if I didn't at least bring it up. Because patients and families actually don't know what to ask for. So it is incumbent upon us all to just keep that in mind, I guess. And again, if it's not relevant to the statute itself, but more the responsibility of the organization, I guess I'd like some clarification on that. I feel it's so important that it needs to be highlighted and it belongs in there if at all possible. At least an acknowledgement, I guess, of the value of it, because we all know that patients and families, if they have insight into available services, information can lead to informed decision making on the part of the family. So I hope that's an appropriate response to your question, but I do think we need to consider that.
So let's go
just-
to the sponsor and ask, when you put this together, Representative Craven, what was the intent in your reference to education? Did you have a specific focus?
Well, I think especially educating families and regarding disposal of leftover medications, if they should die, or if they don't need them any longer, or that sort of thing, and what's available to them, and what they could expect, and that that sort of input.
And who do you think should own that responsibility?
Well, I think that it kind of reminded me of it with Representative Grimlick's bill regarding the home care and hospice situation with the leftover medications, in that families need more education regarding disposal and that sort of thing. And I think that professionally people educate them, that education is available for them otherwise.
So how about education to support the rules as written? Because the rules will reference standards of care, national standards of care. Would that get you close to what you want?
I think so.
We'll have a chance to look at the language, but I see a perplexed look on Anna's face.
No, I can't do two things at once. And I'm just trying to look at the language to, first of all, this is a Lisa Harvey McPherson issue, so you may want to see where she is with this. But I'm just looking to see, I mean, right now the language is written to say something like the rules must include but are not limited to reimbursement policies and quality control measures that ensure and promote high value palliative care. So I don't know whether you want to expand the list of what the rules must include, but that's one potential. I mean, I don't know whether it makes sense to have educational materials and rules or not, but that's because I'm not a practitioner. But that might be a possible place to think about that, if that makes sense in terms of the program, and that's where Lisa might be helpful, or if we still have Molly or not.
Welcome, Ms. Harvey McPherson. Have you been listening, and do you have any thoughts?
Yes, I do, and good morning, everyone. The thinking around education is germane to the bill that's before you today, and moving from a reimbursement structure that has a few isolated codes that providers use to a team-based approach to care that's based on national standards is a pretty substantive change. And the educational partnership with experts in the field, and I agree, there are clinicians in palliative care that are excellent resources. There are so many, Maine has a richness of talent that can support putting together information to advise largely the provider community impacted by the rule to understand the fundamental change. So a primary care doctor really interested in palliative care would understand this is a big shift in how this care is structured and reimbursed, and that's what this rule achieves. in terms of the grassroots communication and cultural change around understanding palliative care. Candace is right, that is really important. But that is a broader context of what I think the hospice and palliative care community at large needs to engage in, not simply solely related to this rule, but culturally, how do we deliver care supporting individual choice that has some challenges in terms of the pathway the patient might take. So Candace is right, it's a bigger, broader issue. I was focused more germane to the rule because it is a big change for providers.
Any comments?
Thank you. Thank you for that input.
Does that give you enough direction to go in, Ms. Brom, if we decide to go down that road?
Sure. I think it would make sense to actually add something into that section about what the rule should include, because I see what Lisa is saying, that that's about communicating to providers who are going to be reimbursed for these services, right, Lisa? That it would be
yes, that's what the
different from
rule
how
achieves.
it used to be. Yeah.
Yep.
So that makes sense to me. I do just want to come back to the issue that you were talking about earlier with respect to the standards issue. So one of the things that we had mentioned the possibility of, this is around the National Coalition, is putting that language in unallocated language. But it sounded like what I heard a little earlier from Candace is that maybe that's not the only organization or the only set of standards. So I'm still a little tiny bit lost about where you might, I just want to make sure you don't lead that up to me. Since that's not my job. So I just want to make sure that if you're going down this road, that piece gets completely sorted out in a way that I know what you're doing. But I'm good on the educational piece.
Okay, so the educational piece for the providers you're good on.
Yeah, we'll add that into the rule requirements. And that's
Okay.
fairly straightforward. It's still the piece about who's going to be providing the advice to the department about that.
Okay. Any thoughts, Ms. Powell?
Again, the Home Care Alliance, we worked with Representative Craven to develop this bill. There's lots of people who have spent years in this field, and a lot of physicians that are not present with us today who would like to weigh in on this. So, the group of people who are experienced in this field are, like Lisa said, Maine is very lucky to have the practitioners that they do. And team members that they do, social workers and nurses. So we have quite a field to choose from. If we're looking at an association, I understood we were trying to stay away from names and just do general category of people who are experienced, maybe licensed. There's a certification for hospice and palliative care. And there are organizations that represent those people. So if we want more general language, I think if we maybe put something in there, and Anna, I don't know if this is possible, and Lisa, jump in. If you want to weigh in on this, but we could request that the department reach out to the organizations in the state that represent palliative care and get their recommendations for people, individuals.
I don't think we need to be referring to specific people. I think finding the stakeholders is going to be easy. I think the reference needs to be in support of national standards of palliative care.
Yeah.
And that leaves it global enough that they can go down whatever they think is the appropriate path. I don't think we need to tie it to individuals or circumstances.
Right. I didn't think you wanted to. I think generally there's so many experienced people, and the standards are reflected in the clinical practice guidelines and the national consensus document. There are some very well-respected documents out there. So I think if we just say national documents that are,
Nationally recognized standards or something like that.
absolutely, absolutely, yeah.
So just to be clear, there are two places that we're talking about here. One is the rule itself and who is advising the department on the rule. The second piece, the stakeholder group, is specifically about educational documents or to the rule. So that's where I'm a little bit confused. Like, are you talking about a stakeholder group that is working on all of the rules now, in which case you wouldn't need this part up here because you'd be saying that the stakeholder group would be advising on developing the rule, which is slightly different. So I'm a little bit confused because there are two different things and I think you're talking about them together. So I'm not entirely clear about where you're going.
Sure. Are you directing that at me, Anna?
I'm directing it to the committee. It's entirely up to all of you how you decide who answers what. That's
okay.
I'm not running.
Well, I think
I'm
in
just
the
asking
first instance, I don't have a line to go by, but it's in section 2 of the rules, third line. That is the one. The development of the rule references the provider rules about how this new process is going to work, and that is going to be based on, as I understand it, some sort of nationally recognized standards. So the department should be using nationally recognized standards to develop rules related to the team care concept. Okay, and then then down further in terms of the stakeholder group, yeah, I don't even think we need line 4.
Right.
I mean, I don't think we need the latter reference to education. You want to highlight?
I'm going to move this off the screen so you can't. Yeah. So this is the part that you're talking about here. So this is about the educational materials related to the rule. So you're saying you don't need
to advise? No, I think we can just leave that as it is.
Okay.
And it should include the word palliative care in there, groups representing home care, palliative care, and hospice providers. I think we have to specifically include palliative care in that line.
Yep.
No, this is a Word document. I could have been doing this as I was going, couldn't I?
And the educational rules is related to adequate work with the greater community or something like that. I mean, it's to make it broader. That group, that convened group, is to help advise about where we need to go for education in our work. Is that accurate? So
I'm not sure who you're asking. I'm sorry.
Okay. Ms. McPherson, would that address that? Yes, go ahead.
So on the rule, it begs the question, why would we want to insert into the rule reference to a national standard?
No.
And the reason that becomes important, from my understanding, is if you look at the general payer community, they don't reflect the national standards around evidence-based practice for palliative care. So we want to guide the department. Don't look at all the other payers. Look at what the national standards are on how palliative care is done and what the evidence is to support that. So that's why we linked the rule to guide the department on where we want them to be advised. And then the stakeholder group, as I said, is a mechanism to work with the provider community to understand this is a big difference in how palliative care was kind of defined and paid for before, and how it will be moving forward.
Okay, so you want to keep it more focused. And the way it stands now, if you can see the screen, is under paragraph 2, it's rules. and it references the national standards.
Mhm.
So that makes sense, and we don't have to touch that.
Yep.
And then the stakeholder group, with the addition of the word palliative,
Yeah.
to advise related to, yes, so that
Yep.
does refer back to the process
Yep.
of developing the rule. This is a way to revisit the rule with input from multiple stakeholders.
And then you might want unallocated language at the end that specifically
Mhm.
refers to these national standards. That would be one way out of it.
When we say such as, we don't have to commit to a specific standard.
Right. Because we can't really. I mean, we could give a suggestion, but this is an organization that could change its name or change the name of its guidelines or.
Yeah. Representative Perry, you've had your hand up. Thank you for being patient.
Yes, well, actually, I'm going through this same thing with you and looking at, I'm sorry you took that down, section 3.
It's coming back.
Okay. Looking at section 3, I think the problem I have is when you're talking about advise on educational documents. That means it has to be in printing. It has to be. Okay. I'm looking at it, maybe educational materials and strategy.
Mm-hmm. Yep. Yep.
That meet that need? Thank you, Representative Perry. That looks better to me. Okay, so Representative Craven, are you comfortable with these changes to this amendments?
Yes, I think it's a good bill. Thank you all so much for working on it.
So these are amendments to the proposed amendment, but I think we're getting to the language we want to. What we haven't resolved is the issue about whether we want to make a statement about broader education or just keep educational requirements specific to the rule about how to do this new system. Any thoughts about that? Should we just keep it focused on the rule in question and trust that the participating organizations know what their communities need? I think that would be my inclination, rather than try and get into too broad a conversation about the need for education, where and how.
Yeah,
Representative
too
Craven?
prescriptive. I would agree.
Yeah.
Oh, thank you. All right. Any other thoughts about that particular issue? Yes, Representative Perry.
Here I am again. I'm thinking that if we want to go beyond that putting strategy in allows them to do that as they move forward and offer opportunities.
Okay. All righty. And then the other issue that we haven't resolved is the request from the American Cancer Society. Can you highlight that again for us, Anna? That was at the top, yeah. Now, the bottom bullet point at the top there. And the request was to add the language about must have access to these services, all main care enrollees. Any thoughts about that request?
I don't know whether you might need to ask the department about that. It's not entirely clear to me why I'm not sure what the issue is. Is the issue about the main care? I mean, whoever is eligible for it is not the issue, so presumably it's not all. It's this issue of like what's appropriate according to, I don't know whether the issue is access or whether it's appropriate according to evidence-based guidelines. I mean,
I think it's access.
I mean, there are all sorts of issues with main care with access. I mean, everybody's supposed to have access to whatever services are required. That's federal law already. We do know that not everybody ends up, people end up on waiting lists, but I don't know.
I just would like to run that by the department if you decide to go to include that. The other thing, well, I have my mic on, is I don't know whether there's an issue with the department, whether they would need to make some kind of state plan amendment or whatever, but it might be worth having some unallocated language about applying for whatever waivers or amendments, state plan amendments are necessary to accomplish this. It's fairly standard language that we often include because it would require, presumably, a state plan amendment.
So the challenge here is must. So now it becomes the way this is written, if, in quotes, the department's responsibility to provide these services to everybody who qualifies appropriately. Is that really the department's responsibility?
I mean, you're requiring it in law. I mean, this is the whole point of writing this, I thought.
Well, that part I understand.
Yeah.
Is that what we intend? Or, and if so, how is that going to happen? Representative Craven?
Thank you, Mr. Chair. Well, the cancer, Ken did not reach out to me at all. And I would rather actually not to make the bill muddier. So I just don't see the purpose of it, because if somebody has a diagnosis and they're referred by their physician, then they'll get the service or not, you know. I don't, so it would be my wish not to include it. Thank you.
Okay, it's your bill. You've done this once or twice before. This is your bill. Any other thoughts about that particular phrase? We don't hear as much support for that from the sponsor. Any other things we could consider related to this bill? Are people ready to vote on it, or other questions, clarifications?
Do you want waiver language or no? I mean, not waiver language, state plan amendment language or not?
I think I heard the representative say she doesn't want to go down that road for the ask can ask. I think the term was muddy. That's an advanced legislative term. Representative Perry.
I think the question being asked is the unallocated language to say whether if there was a need for a state plan amendment or waiver, that language be in there giving them permission to do that.
But that's help me out here, Anna. Is that only apply if we stipulate that everybody who qualifies?
No.
Okay.
That was an unrelated point that I just thought
good.
of
All right.
about
So
5
if
minutes
that's
ago.
related to that particular piece, then I have no trouble with the stipulating language. All right. Yes, Senator Moore.
Yes, thank you, Senator Claxton. I think I'm going to make the motion that ought to pass as amended with all of the work we've done in the last half hour. I think we're ready to go on.
I'll second it.
And there's a second for that motion. Thank you, Senator Moore. Is there any further discussion? I don't see any. So that turns us to Ms. Withy for running the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore? Yes. Representative Meyer?
Yes.
Representative Meyer? Yes. Senator Claxton?
Yes.
Senator Claxton? Yes. That's 10 yes, 3 absent.
Thank you, Ms. Withy. So we'll thank Ms. Powell for being here and helping with that conversation and making a good bill better. And we'll thank Ms. Harvey McPherson for being here to help
And
us
I
with
thank all of you.
clarifying some of this. And Representative Craven, did you have a comment?
Yes, thank you very much. I thank everybody for their vote.
All right, well done. Okay, so in the absence of Representative Madigan, we can go back to LD 432 and have a consideration of that based on Anna's analysis.
You did say 432, correct?
Yes, 432.
Okay. LD 432. This is resolved to improve behavioral health care for children. This resolve requires the HHS to amend Section 65 rules to reimburse for additional collateral contacts for children's home and community-based treatment. Those additional collateral contacts are between the children's mental health professional and parents, medical providers, psychiatric providers, residential providers, case managers, and school personnel, as long as the goal of the collateral contact is included in the goals of the individual treatment plan. And it does not impact the maximum number of hours of collateral contacts that are currently available under the rule. So you heard from the sponsor during the public hearing that a standard of care requires working with others than only the child and the family, and they need to be able to bill for the coordination time. You heard from the Developmental Disabilities Council from Nancy Cronin that she would like to see Section 28 in the bill to include developmental disability in addition to mental health. And you heard from the Alliance that they would like to expand the cap on the number of hours allowed. And the department said that the increased utilization below the current limit is what generates the fiscal impact. So the question is the current collateral contact rules. You can see the rules below. They were also attached to the testimony, and I can go back down. It covers up to 10 hours per year of face-to-face collateral contact. And it wasn't clear to me, and I still don't really know the answer of what collateral contacts are not currently covered, or whether the face-to-face requirement is the issue, or whether the cap of 10 hours is an issue. So I'm just going to go down here. Oops. Oh, and also the Section 28 issue, I did ask about that. Currently, collateral contacts under Section 28 are not a billable activity, but board certified behavioral analysts, which I have to look up BCBA every time, can use up to 2 hours per member per month to conduct care coordination of the members' care with other providers, and they can request additional units. That seem to be the closest equivalent to collateral contacts in Section 28, but Section 28, Section 65, I'm sorry, that the equivalent in Section 28 for collateral contacts is called care coordination. So the OFPR preliminary fiscal impact statement is a general fund appropriation of $2,000 in fiscal year 21-22 and $4,000 in the following year with an FMAP match. And that seems to be based on, if you look at the department's testimony, on whoever is currently not using the full extent of the 10 hours. Which I think is perhaps why you heard some testimony suggesting that the cap was the problem rather than the issue. So just as a reminder what the Section 65 rules are, there's a definition of the of what the collateral contact is, which is this face-to-face contact on behalf of a member to other folks involved in the individual treatment plan, and you can see the cap there. Oops, sorry, I'm having trouble with my third pages today. Oh, that's, yeah, you don't need to worry about that part. So it's just not entirely clear to me whether the issue is actually about the cap rather than the collateral contacts themselves. So I'm a little bit confused, and I was hoping that Representative Madigan would be able to clarify that for me. I did ask the department, but
She's on her way, Anna.
okay. So that's what I have.
Okay. Representative Griffin, you've had your hand up?
Yes, I forget what's PMPM. What does that stand for?
Per member per month.
Say it again.
It just means per member per month. So they can have two, this is under section 28, they can have 2 hours of care coordination for each person per month.
Okay, thank you.
That's the closest equivalent to collateral contacts for section 28. I know I have to look up those things every time too. The one that tricks me, Representative Griffin, is BCBA. I'm like, what does that mean again? Anyway.
We live in a world of abbreviations. All right. Yes, so we've been joined by Representative Madigan. Are you at a place where you can introduce yourself and maybe answer some questions? Or are you still getting settled in to logged on? We'll give her a chance to get settled. Are there questions that this analysis has raised for anybody in the committee related to LD 432? Good morning.
I'm back.
Yes. Just a minute, and we'll get to Representative Perry. You had a question?
Let's let Colleen have her say.
Okay.
That question may be.
Welcome, Representative Madigan. You want to introduce yourself, and have you heard any of this discussion?
Yes, I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland. Particularly in the time of COVID, I'm sorry, I saw Mary Ann doing something. I was like, what? I think that it's important that the collateral contacts also include phone calls. Much of what we do right now is either phone calls or virtually. So having contact with a collateral contact by phone, whether that's school personnel or a child's pediatrician or psychiatric provider, is important, and that often is not happening face to face now. And telehealth is more widely available, and a lot of this stuff is being done. So I think the collateral contact has to include virtual or phone.
So a number of other questions related to collateral contact were raised. Is the 2 hour per member per month in section 28, is that adequate?
I don't think it is adequate. I mean, and I think the rule around contact being in the treatment plan absolutely needs to be there. Obviously, we only want to have that contact. And if that is part of coordinating care, that should be in the treatment plan. So I'm fine with that part of it.
Okay, so does that not define the number of hours? I'm sorry, I'm not sure. Per member per month with that revision? Does that leave it open?
I think it should be open.
So that makes it really hard. That makes it
sorry.
really hard to do a fiscal note, though, if for some people it's 0 and other people it's 100 hours a week.
Well, obviously, it wouldn't be that much. I think there are times, particularly when a child is in crisis, or when you're first initiating care, or when there's involvement, say with Child Protective, where there may be more collateral contact needed. That would obviously be part of someone's individualized treatment plan at that time.
Okay.
Coordinating care means obviously working towards more stability, and hopefully that would be less needed over time.
Okay. Representative Perry, did you get your question answered? You're still muted, though.
I'm not sure. I think the other question I had was, is there at this point a limit on who is collateral consultation?
On who or how long?
On who?
And I think we were just trying to refine the definition of the who by adding telephone contact.
Oh, that doesn't define who.
Well, I know, but
In rule or whatever, it determines who they can contact with the planning of the
okay.
plan.
Okay, Representative Madigan?
In developing an individualized treatment plan, you would identify who those people are in that child's system. You know, that may be school personnel, that may be various psychiatric or other medical providers, OT, you know, whatever those things may be, but those would have to be identified. So it would be anyone who is also involved with the care of the child and care and education of the child.
So there's no particular limitation and in the rule or anything as to who it could be.
I don't think so.
Thank you.
I think that was partially a question for Anna. In the existing rules, is there any definition of who can be collateral contact?
It says here, meet with other service providers to plan and coordinate treatment to ensure the integration of the treatment across the member's home, school, and community to achieve the desired effects and goals identified in this. So I don't think they are. That's why I asked the question.
Yeah.
You know, it says professionals and caregivers from other agencies. That's why I asked the question about whether this is who, how, which is the question that that Representative Madigan did answer, which is face-to-face the problem, or the number of hours. And I just want to revisit that too, because you can see here that section 65, which is what's in the bill, has a limit of 10 hours per year. It's section 28, which is the one that the DD Council are asking for, that has 2 hours a month of care coordination. So you have a number of different things going on here. The way the bill is written is only about the who, which doesn't seem to me to be particularly the problem, unless Representative Madigan understands something that I don't, which is always possible, since this is her world and not mine. But that's why I asked the question about whether the issue is who, the how, the face-to-face issue, or the cap. And then the section 28 is a separate question that didn't come from Representative Madigan, but came from the DD Council. And it's up to you where you want to go with that. But the bill is written only about the who.
Representative Madigan?
So it's the bill also it needs to include the how, so that we know that it can be phone or virtual contact. That was the intent of this. And the cap is a problem. If you're talking about a complex case where there are multiple providers, including child protective involvement, the, 2 hours per month could easily be a problem.
It's 10 hours a year.
Yeah, let's stick with section 65 for right now. That's 10 per year. Is that adequate in the arena of behavioral health? Do you have a proposal in the absence of an IDT?
I mean, we could double that. I think that actually gets closer to what's needed. So if it was 20 hours, that seems to me more fitting of what a clinician doing this would require to coordinate with other providers, including case managers or folks in the educational system or folks in child protective.
Okay. So you'd like to increase that for section 65, which is the bill as it stands now, to 20 hours per year for that work. Okay. And I think we're clear on virtual as well as, yep, so we're good with that. Do you think the who needs any more definition than is already there?
No, I think that covers everyone.
Yeah, okay. So does that answer your questions related to section 65, Anna? We got that ironed out? Okay, so we're good with the bill the way it's proposed. Are you proposing an amendment, Representative Madigan? To include
Yes, I
section 28?
actually, am supportive of the issue that the Developmental Disabilities Council brought up, that section 28 should be included. They're often dealing with complex cases as well.
And
So
in
you
this
would-
case,
Right, you would need to specify those hours because that's already more than what you just doubled for section 65. That's the one that's 2 hours a month.
Right. I mean, I think that should be the same.
you think, but that's going to actually decrease it because 2 hours a month is 24.
Oh, okay.
I don't think that's your intent.
No, that's not my intent.
Do you want to make it per year and have some flexibility?
Yeah, that actually is better. I mean, there are times when that certainly, that would probably make sense if they're dealing with a crisis.
Sure. So, so it's a friendly amendment to make it 24 hours per year, doesn't change the fiscal note.
No, it does not.
Right, but eventually it would roll up or not get used. Yeah, okay. So is that clear enough? So there's an amendment there's a requested amendment to add section 28, which is the services related to cognitive impairments and functional limitations. And those are kid-related and IDT driven.
Yes.
Okay. So the only change we're proposing is A, adding section 28, and B, changing from 2 hours per month to 24 per year.
Yes.
Okay. All right. Is there any conversations about the proposed amendment to add section 28 with that one change? All right. So right now we're looking at an amendment. We're looking at a bill that has been amended and some changes associated with it. You have a clear understanding of what we've talked about at this point, Anna?
Yeah, it's basically a strike and replace because you don't need the who that's in the bill. So you'd be replacing it with the how and the numbers. Yep.
Okay, very good. Are we ready to vote on this? Are folks feeling like they've had a chance to understand the bill? And yes, Senator Moore.
I'm a little bit confused. I understand. I'm totally supportive of adding section 28. I'm trying to get back to the 10 hours of the face-to-face collateral contacts. I know we were talking about adding or by telehealth. Are we changing that 10 hours to 20 hours? That's what I'm not understanding.
Yes, we're changing the 10 to 20.
Okay.
Or at least the sponsor is requesting that.
And that's for section 65, correct?
It is. Yes.
Okay. Gotcha.
So we
Just wanna understand.
increased the hours from 10 to 20. We added virtual to the process. And the existing definition of the who is covered by the virtual and the definition that's already in the bill, already in the law. Okay. Does that answer your question, Senator Moore? Okay. So I guess at this point, I'm looking for a motion.
I move ought to pass as amended.
Second.
So the motion's been made and seconded, ought to pass as amended. Do folks want me to review the amendments or are we good about that? We're good? Okay, so that lets us go to Representative Lemelin, were you nodding to me or to somebody else? Or were you shaking your head, yes, you want to have the amendments clarified?
No, sir. I was just shaking my head.
Okay.
Yes.
Okay. All right. Very good. It'd be easier in a committee room, but to read language. Okay. So Ms. Withy, we're ready to vote on a motion ought to pass as amended, which has been made and seconded.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Sorry, yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 11 yes, 2 absent.
Thank you. And even though Senator Moore sometimes has an echo, she only gets 1 vote. All right, so it's after, I think we have been rejoined by Ms. Bogart. So let's bring her into the room and we can move to consideration of LD 958. There's been some discussions related to that bill. Welcome, Ms. Bogart, and welcome, Senator Maxman.
Morning.
Good morning. So who would like to speak to some of the work that's been done on 958? Senator Maxman, or would you?
I'm actually going to pass it over to Ms. Bogart.
Very good. Ms. Bogart, welcome.
Yes, thank you. So for the record, I'm Molly Bogart, Director of Government Relations for DHHS, and appreciate Senator Maxman's willingness to work on this with us. The recommendation that we have is to, rather than focus on the rules themselves, request that the department review our statutory authority related to the oversight of these programs and home care agencies specifically. A lot of the challenge that we have is that we don't have the statutory authority to provide the level of oversight or intervention that constituents at the public hearing were looking for. And so having the department review that authority and report back to you with recommendations next year, early next session, about what statutory authority changes may need to be made and any cost or structural changes that would be associated with that, I think would get us to the place that constituents are looking for, which would eventually mean were they to be enacted by the legislature, statutory changes that would allow us to address some of these, bad actors or have better interventions when there are specific concerns like those that were raised at the public hearing. And so following that, the longer process that would be our review and report to you, you could determine whether any recommendations should be enacted in law. And then that would be the point at which authority may theoretically be enhanced, and we could do the reviews of the rules and sections that have been identified to update them with any changes to our oversight.
Very good. And that sounds good to you, Senator Maxman?
Yeah, that makes sense to me. And I just wanted to reiterate that a lot of the advocates that I've been working on this bill with have had particular interest in Chapter 129, which is the rules and regulations governing in-home care, personal care, and support workers. And so just wanted to put on the committee record that would be the an immediate next step after this review from the department came back next year.
So that would make a lot of sense to reviewing rules that were meeting the needs of the any requested statutory changes. That makes sense. Okay. Ms. Broom, we kind of skipped over your analysis, but I knew that the bill was going to change. Does that change your analysis substantially?
We don't need to do the analysis, and Molly had given me a heads up, so
Okay.
fine.
All right. Representative Perry, did you have your hand up?
Yeah, and again, looking at this, I'm assuming with a report back that would allow the committee to report out some in legislation.
That would be the intent. We'll make that a standing Perry amendment for any of these bills. All right. Any other discussion about this newly amended version of 958, which changes it to a statutory authority review, a report back, and an opportunity to request any changes to statute of the committee, the report back coming early in 2022? Is that an accurate summary of the amendment? The amended version of the bill? Okay, so the sponsor's okay with it. Molly's nodding her head. That makes it Anna's turn to ask questions.
Are you okay with January 1st, Molly?
Sure.
Okay.
Any other questions? I don't see any, so then I would, yes, so Representative Griffin?
I just wanted to say that I agree with that, working with the department and this amendment.
Do you want to change, turn that into a motion to ought to pass as amended?
Sure, I'll make that
Thank you.
motion.
Thank you. And there's a second. All right. Is there any additional discussion of the motion on the floor, which is ought to pass as amended? I don't see any, so it becomes Ms. Withy's turn.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
We may have to ask Representative Lemlin to kill his video. You didn't hear that, Representative Lemlin.
I'm a yes, if you can hear me now.
Yes. Thank
Yes.
you.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 11 yes, 2 absent.
Very good. So now we'll proceed to consideration of 1091, and we'll bring Senator Curry and Mr. Landry into our panelist role. Welcome, gentlemen. We'll start by hearing from Ms. Broom.
Okay. All right. I don't have a lot for this one. This is an act to improve the long-term outcomes for youth transitioning from state care by raising the upper age limit for voluntary support eligibility. This bill raises the upper age limit from 20 to 22 years of age for voluntary participation in extended care for persons who attained 18 years of age while in care and custody of the state. And it makes a corresponding change to the transition grant program for individuals exiting extended care and pursuing a post-secondary education by changing the requirement that to be eligible to participate in the program, an individual must be 21 to a requirement that an individual must be at least 23. You heard from the department, neither for nor against, about the December 2020 Consolidated Appropriations Act, including the Supporting Foster Youth and Families Through the Pandemic Act, that included a temporary suspension of aging out of foster care and permitting re-entry of youth who have left foster care until September 30th of 2021, and that comes with funding. They are not opposed to increasing the age, but this gives the opportunity to study the impact with federal funds because it does require state funds in the long term. And you did also hear from the sponsor that what happens in October when that funding ends. So you asked the department for their plans for outreach, and I know that you received them by email as well. I can put that up on the screen if you'd like, but you may just want to go straight to Dr. Landry and Senator Curry. I know that you also received something since committee began from Senator Curry.
Okay. So why don't we hear from the sponsor then? Is there additional information we should have in considering your bill? Welcome.
Thank you, Mr. Chair. I have what I sent to you earlier was a handout that's given to youth who are aging out of care, and it lists all of the different supports that are available to them. So it's a good overview of the it's a grid of overview and eligibility for the various types of supports. One of the things I'm still an advocate of is being aware of the October, that some youth will be will not be eligible for the V9. I have a larger goal around this of reducing the disparities between youth who are in foster care after age 14, disparities in compared to their family supported youth, and especially in terms of housing, education, and a number of thriving factors. And so how do we best do this? And this is one tool. This won't solve it. This won't solve it alone. We have a small number of youth. I believe the last data I have, and Dr. Landry, I'm sure can correct me on this, was from 2018, where we had 72 youth that were aging out of care at 18, and we only had 13 who were in care under what's called the V9 or the extended care agreement who were 19. So it really drops off in terms of the number of youth that are taking advantage of it. The one thing I am aware, if you're looking at that chart, there is a really effective alumni transition grant program where there's good supports for youth who are going to college. But that's the other disparity that I would really love the department or for us to be able to have, is to find greater supports for those who are not going to college and not pursuing post-secondary education. I come at this from a place of appreciation. The OCFS cares about this deeply and has been working on this issue for a long time. And yet, these are our kids, where we take on the role of parent, and when we see outcomes that are less than that we think can be much better, then I think we need to be engaging in that. And so by increasing this this age limit, at this point, it's another tool, another option for the department and for youth in order to achieve the developmental needs of our young adults.
Okay, any questions of Senator Curry? I don't see any. Director Landry, did you want to chime in here?
The only thing I would say is I'm happy to answer questions. I probably overwhelmed you with a lot of information about the Extended Support Pandemic Relief Program, but in the spirit of transparency, wanted you to have all of that information. We continue to believe that it would be best if we were able to use this federal opportunity in order to study what is working, what is needed, and what would work best before we consider a permanent statutory change in the state, including state general fund dollars, and would be happy to work with the sponsor and or any other members of this committee on potential future changes. I will say that as of this morning, we have 66 youth that are on the quote unquote V9 agreements. And so that is the current number that we have as of this morning.
And so are there elements, Senator Curry, of your bill that aren't covered by the emergency circumstances?
Thank you for the question. Yes, October 1 isn't covered on the emergency circumstance. And
Okay.
so the timing on that is great for a bill that we passed this session is that we're 90 days after adjournment, we're there. And so I think that's the concern. I would love to have a study. I'd love to have a study included in this and to look at the broad areas of how we're supporting youth, not just within the V9, but also within looking at all the other supports to see what is working. But I am concerned about the immediate question of what happens to the youth who are youth and the youth, especially the youth who are over 20 after October 1.
Director Landry, did I remember a conversation when you testified earlier? Excuse me if I'm drawing a blank on it, but you thought the emergency would be extended and that
There's
might.
the potential. I'm sorry to interrupt you. There is the potential that is being discussed at the federal level currently as additional considerations on relief provisions related to the pandemic continue to have further discussions. So it is being actively considered and discussed in the appropriate congressional subcommittees and committees. I would like to point out, just for clarification, the current federal authorization and requirement takes it all the way to age 27. And so come the end of September, regardless of whether the committee passes and the legislature passes the proposal by the sponsor or not, there's going to be some number of youth that we will be working with as the end of September approaches or whenever the federal authorization ends in order to help them transition, which is something that we always do with any of our youth on V9s, whatever age that they may be ending their services at.
And the age range for that group that you'll be working with as 10-1 approaches, barring any extension of the emergency room, what's the age range there?
Barring any extension at that point, it would be those youth that are over the age of, right now, the current state statute goes to age 21. And so it would be over age 21.
Okay. Does anybody need additional information to get ready to vote on this? So I haven't heard any amendments. Am I right about that, Senator Curry?
I have not put forward any amendments. Yeah.
Okay. Any questions? Would someone like to make a motion?
Chair, I move ought to pass, LD 1091 ought to pass.
I'll second.
So the motion has been made and seconded. Is there additional discussion? Then I guess, Ms. Withy, you can run the vote total.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 11 yes, 2 absent.
I would expect that that may well have a fiscal note, so you should record that as an ought to pass as amended, Kerry. In the meantime, at least, until we get something that says something different.
Thank you. All right. So thank you, Director Landry, and thank you, sponsor Senator Curry.
Thank you. Thank you very much, Senator Claxton and committee.
Thank you for being here. Thanks for the deliberation. So that gets us to LD 1112 and Ms. Broom.
$11.12. This is resolved to classify employee health insurance as a fixed cost for main care and reimbursement in nursing homes. This resolve requires the department to amend its principles of reimbursement for nursing facilities at section 67, no later than January 1st of 2022 to move health insurance from we'll try that again. To move health insurance costs for personnel from direct care and routine cost components, that depends on which personnel you're talking about, to fixed cost components. This was a majority recommendation of the Commission to Study Long-Term Care Facilities that was reported in December 2013. So the fixed cost component is more like a pass-through, which doesn't have without the caps, which is why it why the nursing facilities would like it, but also why there would be a cost. There are caps on direct care and routine cost components. The proponents, the cost of providing health insurance outpace the COLAs that are coming in under the law, and they end up paying more and charging more of the healthcare insurance costs to the staff. Providers absorb the cost in the year between rebasing, which, as you remember, Senator Claxton brought this up during the public hearing. The rebasing is every 2 years, and the cost is a particular issue in between. This is exactly the same bill as LD 1126 and the 129th. We haven't yet received the fiscal note from OFPR, but I did look up the LD 1126 fiscal note, and the full cost, the full year cost, as you know, it's always less than the first year because it's not a full year. The full year cost is 5.6 million in general fund, with corresponding 11.9 million in federal funds and 1.1 in other special revenue. In other words, there will be a fiscal note of a substantial size, but we do not have it yet.
Any questions of that analysis? Any questions in general related to this bill? I don't see any. I guess at that point then, I'd entertain a motion. Representative Craven.
Thank you, Mr. Chair. I move ought to pass as amended.
Is there a second? Yes, and a second from Representative Connor. Thank you. Any additional discussion? Seeing none, we'll proceed to give Ms. Withy the floor to run the vote.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yeah.
that sounded like a yes.
I heard a yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci, Senator Baldacci is absent. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner, Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 11 yes, 2 absent.
Very good. Thank you. So we've had a request for a 5-minute break. Sounds like a good plan to me. We'll come back and consider LD 1197. Thank you for that suggestion, Representative Lemelin. We'll be back at 11:45. So it's 11:45 and we're back to our work session in Health and Human Services. We have another bill to consider this morning. It's 1197. And we'll turn it over to Anna.
Okay, 1197. This is a resolve to require continued main care reimbursement to nursing facilities for bed hold days during hospitalization and therapeutic leaves of absence. This is probably going to feel like a familiar issue to you. So this resolve requires the department to continue to provide reimbursement under the main care program to nursing facilities for direct costs on bed hold days during hospitalization and therapeutic leaves of absence. So you heard during the public hearing and a number of other times this year that the bed hold provision protects residents while they're out of the facility and the costs in a hospital, for example, and the costs of staffing continue even if a bed is empty. And you also heard from the department that fixed and routine costs are reimbursed during approved bed hold days, but the direct care portion may only be paid when the work is performed, and that many providers have abided by this rule, and that rule is mirrored in the state plan. So the bill is drafted with an October 6th, 2020 date, and that is problematic if your intent is FMAP match. And you heard about this issue yesterday, I believe, when you were talking about, I think it was a substance use disorder bill that you were doing with Erin. So putting aside the direct care costs, assuming that direct care costs can be reimbursed when a member is not in a facility, reimbursement can only be retroactive to the beginning of the quarter in which a change is submitted to the CMS. So as the department told you that the rule is currently in the state plan, that would mean that they would need to make a state plan amendment request. So if the bill is signed into law in June, the department would submit the change during the first quarter of state fiscal year 2022 between July and September. And so the earliest there would be federal match is July 1st, 2021. And so you have a couple of choices here if you want to move forward with this. The one is to change the date or take the date out altogether and just have a state plan amendment requirement to be submitted by, a certain period of time. Or you have a retroactive increase to October the 6th as, and I don't know where that date comes from, to October the 6th of 2020, and that cost would be charged to all general fund. So those are your options if you want to move forward with the bill. And we haven't yet received a fiscal impact statement, but there will be something.
Yes, Representative Craven.
Thank you, Mr. Chair. I would suggest not putting any date in it and just having the department be able to proceed after the bill becomes law.
All right. So any other thoughts about that? Yes, Representative Meyer.
I'm wondering, thank you, Mr. Chair. I'm wondering, where did 10-6 come from?
It's a Tuesday in October last year. I can't figure out why.
Okay.
Maybe Rick Erb knows the answer to that. I mean, presumably it comes from the advocates. I don't know.
In the absence of such, I'm not sure it helps us much. Representative Craven?
No, it comes from the advocates.
Okay. So just so I understand the implications, if we make it retroactive to whenever, it's coming out of general funds entirely.
Sure. My name is Rick Erb. I'm the President and CEO of Maine Healthcare Association. Thank you for inviting me in. We did not participate in the drafting of this bill. One of my members did speak to, I think it was Senator Baldacci. As the chair has mentioned, this is the third time we fought for this particular piece of funding, so I'm very familiar with it. My guess is that October 6th may have been the date that the department first announced that they would be not fully reimbursing for direct care costs. So I would guess that might be where it came from. We would like to see it as retroactive as possible, keeping in mind it's not a tremendously large fiscal note. We're eager to see this put into statute. So whatever way it comes out, we're going to be happy to see it if there's a way to make it retro so that they don't lose the money going back to October. That would obviously be appreciated. Thank you.
Thank you, Mr. Erb. Thank you for being here. Does that raise any questions for anybody? Does that change your thinking, Representative Craven, in terms of removing the date?
Well, I would rather not have the to wait for federal reimbursement, not having retroactive back far enough for the state to have to pay for it.
And when would the federal dollars kick in? Anna?
Well, first of all, you don't have a state plan amendment language in here, which you would probably want to add. But if it's approved, my understanding is you can't go beyond the beginning of that quarter.
Right.
And that I all learned from Luke, really. It's a bit over my head. But I think you were made aware of this particular issue with Mancare yesterday as well, because it applies to any kind of state plan amendment.
Right. So the best that could happen is they get it squared away with the plan amendment in this quarter.
At the best, that what Luke said is if the bill is signed into law in June, which presumably would be the earliest that it could happen, then the department would submit that change request, assuming you put that language in the first quarter between July and September. So the earliest that you could have federal match is July 1. So you could put a July 1 date in there. That would be the easiest way. I don't know if you want to deal with the issue of what happens if a state plan amendment is not granted. I don't know whether you need language about what happens if permission isn't received, or you can just say that it goes forward if permission is received. There are a number of different ways you could go about it. You could require the state plan amendment and say this goes forward if it's received. You could say if it's not received, then the state has to pay for it with general fund. I mean, you have different options.
Representative Craven, does that shape your thinking at all in terms of how you'd like to handle this?
Yeah, I think I'd prefer the language that says if the state plan goes forward, that we should set the date, set it a July 1st date, and if the state plan goes forward, then we will take it from there.
How does that sound to the rest of the committee?
So just to clarify, Representative Craven, that would mean if the state plan amendment was not approved, then this wouldn't go forward. Is that correct? I think that's what I understood you to say.
That we'd have to wait for the next quarter.
No, I mean, if CMS denies the request, then this wouldn't go forward. That's the implication. I just want to make sure that's correct. That's what I understood. Okay.
Representative Connor?
Thank you, Mr. Chair. I was going to move ought to pass as amended with the July date.
And the amendment being state plan request for change.
That's correct, sir.
Is there a second for that motion?
I'll second it.
Okay, sounds like it's been moved and seconded several times. And any further questions or discussion? So I assume the committee is then ready to vote on this. Go ahead, Ms. Withy.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lumlin.
Yes.
Representative Lumlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner, Representative Javner is absent. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 11 yes, 2 absent.
Very good.
Thank you very much. Thank you.
Thank you for being here, Mr. Erb. Thank you, Representative Craven, for hopefully we won't have to deal with bed hold days for the rest of this session. All right. Is there other business to be conducted before we entertain a motion to adjourn and then reconvene at 1 for a presentation about ambulance circumstances and a work session and a public hearing? I don't see Anna with any other additional business. So I would entertain a motion to adjourn until 1 o'clock.
I moved.
Second.
All those in favor? Unanimous of those present. Thank you all, and we'll see everybody at 1. all set, Representative Meyer, when you're ready.
I am. Thank you, Mr.
Thank you for
Chair.
taking care.
Good afternoon and welcome to the PM session of the Joint Standing Committee on Health and Human Services. We're assembled around our virtual horseshoe and live streamed on the HHS channel found on the Maine State Legislature's YouTube channel, where you can find the replay of our proceedings should you miss us live. This afternoon, we will have a presentation from Mr. Joe Kellner, who will talk to us about the situation with the rural ambulance services, followed by four public hearings this afternoon to be heard in the following order: LD 423, LD 1386, LD 1325, LD 1344. We will do just a quick round of introductions, beginning with Representative Zager.
Thank you, Madam Chair. Good afternoon. My name is Sam Zager. I represent District 41 in Portland.
And Representative Lemelin.
Good afternoon. I'm Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover? Yes. You're on mute, Representative Stover.
Thank you. Good afternoon. My name is Holly Stover. I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, West Port Island, and part of South Bristol.
And Representative Perry.
Good afternoon. I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
I am not seeing Representative Craven, so I'll go to Representative Madigan.
Good afternoon. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
And Representative Griffin.
Good afternoon. My name is Abigail Griffin, and I represent House District 102, which is Glumber, Levant, and Cadusky.
Senator Moore. Senator Moore, you're on mute.
I'm sorry, I wasn't, I apologize for that. Good afternoon. My name is Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Craven.
Thank you, Madam Chair. Good afternoon. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
My Senate co-chair, Senator Claxton.
Hello, I'm Ned Claxton. I represent Senate District 20, which includes Auburn, Minot, Mechanic Falls, Poland, and New Gloucester.
And I am Representative Michelle Meyer, proudly serving Southern Maine's House District 2, which is all of Elliott and parts of South Berwick and Kittery. With us this afternoon is our analyst, Ms. Broom.
Hi, I'm Anna Broom. I'm one of the legislative analysts for the Health and Human Services Committee, and I work for the Nonpartisan Office of Policy and Legal Analysis. And I just have to say hi to Jay Bradshaw.
And the glue that holds us all together, our clerk.
Good afternoon. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
And with that, I will welcome Mr. Kellner to present to us. Welcome.
Good afternoon, everybody, and thank you for having me. I understand we have about 45 minutes to an hour today. I will try to be brief and respectful of your time and focus on the applicable parts of this that fall within the Health and Human Services Committee's jurisdiction.
Would you rather wait to take questions, or would you want me to recognize hands that go up?
Stop me anytime. More than happy to answer questions as we go.
Sure thing.
What I thought might be helpful today is to run through the same presentation that we gave to the Health Coverage Insurance and Financial Services Committee, perhaps at a bit of a brisker pace than I did with them. It, I think, is important in setting the foundation for what we'll discuss as part of the jurisdiction of this committee. So I'm going to jump right into that, if that's okay. let me see here. There we go. So this committee was formed in response to LD 2105, which was targeted at eliminating surprise emergency medical bills. 2105, through the work on that, it was recognized that ambulance services are in a bit of a unique position where we're not usually chosen by the person calling us. They call 911, we respond and we care for them. And the patient doesn't have a lot of input or ability to distinguish between services that might be in network with their carriers and not. So this committee looked at a number of things, but primarily the goal was figure out ways to work with commercial insurance carriers to get more ambulance providers in network, understand the barriers to providers being in network, and do some work on the costs and establishing what drives the cost of the EMS system. As a point of information, I have on your screen the members of the committee, which I believe this document was also circulated to you, so I'm not going to get stuck on that for too long. As some disclaimers, I think it's important just to be forthcoming about who I'm employed by and other organizations with which I have a relationship. So I am the Vice President of Finance, one of several employed by Northern Light Health. I oversee the finance parts of Northern Light Home Care and Hospice, Northern Light Medical Transport, which is the ambulance service based in Bangor and Ellsworth, as well as Life Flight of Maine. I also chair the Maine EMS board, and I serve as the treasurer of the Maine Ambulance Association. My role here for this project was chairing the committee, the LD 2105 committee, which, as you saw, was a multidisciplinary group that represented carriers, EMS services, and other stakeholders. My goal in presenting here today is to leave my biases on the table and present objectively what the committee unanimously recommended. And I will do my best to do that. If at any point I feel like I'm putting a different hat on, I will indicate so as we answer the questions. So general background, this is really, as I discussed, it basically delayed the implementation of the surprise emergency medical billing regulations on ambulance services, but did put in a fix to protect patients, whereby ambulance services were entitled to be paid their charges if they were out of network with a Maine-based fully insured plan. There's also some federal activity going on that's important to be aware of, and that is HR 133, the No Surprises Act. Incidentally, without any collaboration or collusion, the federal government came to a similar conclusion that ambulance services needed to be looked at separately. And likewise, similar to what Maine did, is in the process of establishing a stakeholder group to try and deal with this complex issue. A bit of a background on the Maine EMS system. As of the writing of the data in 2019, there were 161 transporting ambulance services, 112 non-transporting services, and 1 air ambulance service. So the non-transporting services are several fire departments in the state, first responder agencies that go and provide care until a transporting ambulance can get to the scene. Life Flight of Maine is the only air ambulance service, and it did fall outside of the committee's jurisdiction. There are 5,549 licensed EMS clinicians in the state as of this data. Each year, 279,601 EMS activations, of which roughly 204,000 of those are 911 emergency calls, the balance being inter-hospital or non-emergency activations. As we did our data analysis, we looked at 3 primary sources. We did a survey of ambulance providers, services, and clinicians within the state of Maine. We surveyed the carriers that are part of the Maine Association of Health Plans, and we looked at data provided by the Maine Health Data Organization to be an objective source of information. Focusing first on the survey of the EMS constituents, we had a 27% response rate of the transporting ambulance services. On average, the average respondent responded to about 1,700 911 requests per year. Of note, 22.5% of the 911 requests that came in for those respondents do not result in a transport and generally don't result in payment. So I want to really underscore that point because I will reflect on that a little bit later when we talk about the Maine care rates. Several of the services reported that there's substantial uncovered costs of care, and they stay in business through cost shifting, essentially. You can see what those cost shifting methodologies look like. So a decent amount of grant money, the biggest pool here being municipal subsidies. Generally, that's done in the form of a per capita payment for ambulance services to the ambulance service provider. Tax coverage applies only to municipal-based services that are being funded. Their gaps in cost to revenue are being funded through tax coverage. Seem to go the wrong way. Some other key findings. On average, the expense per 911 transport is just under $2,000. The expense for all responses is about $654. So what that is saying is if you allocate the costs only to the 911 calls that result in a transport, the cost is about $2,000. If you allocate that cost across the board to all responses, that cost is about $650. And this really goes to the point of those non-transports that don't get any reimbursement. I'm going to skip that page. Notes on why ambulance services choose to be on a network. Commercial insurers are generally relied upon to cover the losses from Medicare, main care, and self-pay. The ambulance services that responded reported that the rates that were being offered by the commercial insurance carriers were too low or below their cost. Some services did report that carriers were unwilling to negotiate for higher rates. They would give a set rack rate and say, this is it, no negotiation. The time frame for initial claim submission is too short. This one came up a lot, that the timely filing guidelines were too short with some of the insurance carriers. And the significant administrative time and expertise required for contracting is not often available to smaller services, of which there are many in Maine. And just to note that those were themes from some open-ended questions. The Maine Association of Health Plans survey surveyed the carriers that are in their association. This part we found particularly interesting, that the majority of carriers had only between 3 and 8 ambulance providers in network. Again, underscoring that there are 161 transporting ambulance services in the state. Anthem is an outlier, substantial outlier. At the time we were speaking, 2-3 months ago, it was 86 services that were participating with them out of 161. Of note, some services did exit the carrier network since the passage of LD 2105 to take advantage of the payment for charges. Many providers don't contract and don't respond to outreach efforts to contract. Again, that's the perception of the insurance carriers. Some providers struggle to meet the operational policies and procedures of the plan, and there's large variation in charges, making it difficult to establish what's reasonable and customary. So we heard this a lot from our colleagues at the insurance plans, that there's substantial variation in what they get charged, and they have a very difficult time establishing what the actual costs are of performing the service and how those costs vary by geography, rurality, etc. Other notes, they have challenges finding providers that can transport complex patients between facilities, especially in rural areas. We see this and hear this often, that hospitals and other facilities have an extremely difficult time these days locating ambulance services that have the staffing or capability to move patients from one facility to another, usually lower level to higher level of care. The current statutory language does not incentivize participation, and some providers have taken advantage of the higher reimbursement by becoming non-participating with the health plans. So that was the feedback from the carriers. Maine Health Data Organization provided some really insightful data, and I want to underscore how impressed I am with the work that this group does. You can see here a map of where the ambulance services are located, overlaid on population, with the darker blue being the highest population, the lighter yellow being the lowest. So you can see where the concentration is, and you can probably see areas where you don't want to need an ambulance immediately. That's where our friends in the air ambulance side come in. From the MHDO data set based on claims, this is the payer mix that they looked at. So this is an important piece that the committee wanted me to note anytime I give this presentation, that the universe of claims impacted by LD 2105 is only 9% when it comes to commercial carriers. Medicaid, however, represents about 23%, and that will speak to our conversation that will follow this presentation. So from MHDO data, they had 693 unique ambulance providers submitted claims, of which 530 of those are located outside of Maine. So to translate that a little bit, if a patient has a Anthem plan in Maine and they're traveling in Texas and get transported by an ambulance, that would count as an out-of-state provider. Very few of those claims, as you can see, 37,000 came from out of state compared to the universe of claims, which is about 1.2 million. The top 10 ambulance services in the state submit 44% of all the claims, and the top 2 submit 10% of all the claims. One thing that was notable is out-of-state services are charging substantially more than in-state services and are paid somewhat more. So generally speaking, when we look at the payments that are made from the commercial carriers, it was 1.2 to 3.7 times what is being paid on average for the same codes in Maine. Maine services generally paid 1.14 to 1.68 times the Medicare rack rates, which I think, as this committee knows, generally match the Maine care rates. Another view that shows the same thing, green being what's paid to out-of-state providers, red being what's paid to in-state providers, and blue being the baseline, which is Medicare. This is showed as a multiplier of Medicare. So you can see again, the substantial difference, especially in the higher level codes, ALS2 and specialty care transport paid to our out-of-state colleagues versus our in-state colleagues by the commercial carriers. This shows you the median charge, and this looks at the 2019 median charge compared to the 2020 Q1. We didn't have data for the time period after 2105 went into effect, but what this does show you is the change in charges. It's relatively small period over period, though there was the outlier there as well. But it does appear that many providers charge less than their cost in the state of Maine, and we can also see that through the subsidy information that was provided by the providers themselves. So again, lots of coverage through taxes, philanthropy, or other subsidies. This shows you the top services by volume and their contract status. Again, I won't spend a ton of time on it, but you can see what the top 10 services are and with whom they are in network. As you get down to number 3 and then onward, you can see that the majority is non-participating versus participating as of the writing of this with the commercial carriers. So that's one of the pieces the group is working to fix. So jumping into our recommendations. So the committee was unanimous in its agreement that surprise billing, even in the ambulance services world, should indeed be eliminated. Patients shouldn't get bills that they're not expecting or that go above and beyond that which their plan pays. In order to do this, we suggested that an incentive is created for providers to participate in network. Patients cannot be charged beyond their copay and deductibles in emergency situations. Any non-covered charges, patients must agree to in advance and in writing for all non-emergency services. We recommended that disputed charges be paid at the median in-network rate if there is to be a dispute resolution process, though that was not put into the draft bill by the other committee. Same with the IDR process, they left that out. And we recommended adopting the Medicare definitions of emergency and non-emergency response. Recommendation 2 is improving reimbursement for rural and low volume services. So this is where our conversation today really picks up. Maine Care must adopt the Medicare recognition of rural and super rural add-on payments. I want to pause on that and explain what that means for a second. So through some really great work and collaboration a couple of years back, we were successful in having the Maine Care ambulance service rates based off the Medicare rates, paid at 100% of the average Medicare rate for those codes. One of the things that Medicare does is in areas that are considered by zip code to be rural or super rural, they add a percentage on 3% or 22.5% respectively. So the challenge here is that services in our very rural areas, take Fort Kent, for example, their call volume is substantially lower than that of an urban service, while the fixed costs of providing an ambulance remain relatively flat. So Medicare has recognized that, and they saw wisdom in bumping up the payment for those services, recognizing that the cost of providing that service to the constituents is higher. When Maine Care adopted this approach of matching the Medicare rate, they did not adopt the approach of what we refer to as the add-on payments. So the ask, and what is highlighted in the memo from the other committee to this committee, is to have Maine Care consider matching that methodology, again ensuring that the reimbursement is in the right place to cover costs as much as possible. So that's that piece. Main Care should also explore cost-based reimbursement for services in underserved areas similar to a CAH model. That's something we're recommending that this committee consider. Commercial carriers should also recognize increased costs for rural and low volume providers. So that is in the legislation that has been proposed, that commercial carriers do also need to recognize this rural and super rural add-on payment. Other pieces that I think this committee will find interesting, we are recommending improving and maintaining efficiency in the system. So this chart is pretty interesting. You can look at volume by providers, and you can see the quartiles in the lower left of that image. So if you remove the top 5 agencies, the average number of calls is 700. My general rule, looking at the finances behind an ambulance service, is without subsidy, to break even on your fixed costs, you need to do approximately 2,000 911 calls per year. So you can see that it's a pretty simplistic look, but if the average number of calls by service is 700 and a half, there's got to be other coverage from somewhere if it's not coming from reimbursement from payers. So we are recommending that Maine EMS establish within 12 months through a rule or statutory change, a process by which delivery efficiency must be established before granting a new service license. So this smells a lot like a CON. And I know that's, it's certainly a hot topic these days on whether the CON process is valid, valuable, or not. There are other approaches to this. There's the informed community self-determination model, which is a relatively new model that's recommended for communities to go through before they look at starting up their own ambulance service, just simply to ensure that they're really looking at the costs and trying to encourage folks to work in a regionalized approach to spread the fixed costs over multiple communities. This is something that the committee thought was really important, especially in the southern part of the state where there's a much higher volume of ambulance providers and the barriers to entry are relatively low. So some type of model to establish need before granting of a license was recommended by the group. Recommendation 4 is aligning reimbursement with the costs. So we want to essentially set a standardized reimbursement rate that seeks to strike a balance between ambulance providers and plan participants. So what we don't want to necessarily always rely on is shifting the losses to the commercial carriers, which does indeed, with respect to them, raise the premiums they need to charge their members and the businesses that provide the plans. We recommend tying the standardized rates to a multiplier of Medicare, similar to what we did with Main Care 1.0. We're recommending a higher rate for commercial carriers, which is 200%, which was the unanimous decision of the committee. The multiplier should be based on the urban rate. We mentioned that. I'm going to get into cost reporting next because I think that's really important. We're in a couple of points, sorry. We did recommend standardized terms for services that may not have the administrative support or foundations to be able to negotiate contracts. Another piece in here, we noted that ambulance services felt that the time to file claims was too short. We're recommending a standard around 120 days. There are a couple of carriers that are at 90 right now. Medicare and Main Care remain at 365. So the cost reporting program, this is another piece that we felt was important in establishing what reasonable and customary rates are. Medicare is requiring cost reporting for ambulance services. They don't necessarily have to do it, but if they don't do it, they take a 10% haircut on their reimbursement. So the tool is already going to exist. We recommend that Maine adopt that tool and collect cost reporting data for ambulance services, which are used to set the rate and further to tie requiring the standard offer from the commercial carriers to services submitting cost report data. We think that's really important. Recommendation 7 is a phased reimbursement model for participation. So again, we're looking at cost reporting as the ultimate best practice to establish what the right reimbursements are to ensure services are paid at their cost plus a small margin. But in the interim, we recommended that services are paid 200% of Medicare if they are not in network, plus any rural or super rural add-ons. If services choose to be out of network, the standard rate's 180% of Medicare. And again, no balance billing is allowed. This would limit services from increasing their charges by more than 5% per year. So if a service is currently charging, 1.5 times Medicare, they couldn't say, "Oh, this legislation is great and favorable. We're just going to jump up to 200% to benefit from that increase." Establishing a process to adjudicate out-of-network claims. I won't spend a lot of time on this because the other committee rejected this in their development of the bill, feeling that setting the standard rate was enough and eliminated the need for the IDR process, which I think is a fair assessment. And I want to spend a little bit more time on this one, establishing an advisory commission that does a number of things, but looks at variable reimbursement based on patient acuity, looks at paying for transports to alternate destinations, reimbursement for services that don't result in a transport, incentivizing increases in efficiency, making recommendations for standardization of prior authorization, medical necessity, and medical reasonableness, looking at how carriers pay for ancillary services above and beyond mileage and base rates, establishing reimbursement for innovative service models. I'm going to take the first point last. We've talked about it here before, establishing reimbursement for community paramedicine programs, including telehealth, to decrease overall system costs. There's some information here on the approaches other states have taken. I'm just going to let you look at that at your leisure. It applies more to the commercial carriers and the other committee. But with that, I'm going to stop the share, and I wanted to talk a little bit more without a PowerPoint in front about kind of what we see with MaineCare and reflect on the rate study that was done and some of the recommendations that were in that rate study, because I think that's important to note as well. So MaineCare right now does have a handful of codes that Medicare doesn't, and MaineCare also allows for payment to a physician office. So there are some areas where MaineCare does differ from Medicare. Some of those codes include ambulance service wait time. There's a reduction in payment for out-of-state mileage. Medicare doesn't do that. As we reflected on the consultant report and their recommendations, they did point out that there are things that MaineCare pays for that Medicare does not, and they pay at 240% of the Medicare rate. Myself and my colleagues haven't been able to identify what that group specifically was referring to. So for example, the ambulance wait time payment, Medicare pays $0. The MaineCare fee schedule pays $95. That's not 240%, so we couldn't really put our finger on that. The important point is the codes that are billed most regularly for ambulance services are the same as Medicare. The only gap is that MaineCare doesn't pay the rural and super rural add-ons. So again, we're asking the committee to consider some sort of directive to MaineCare to look at those zip code based add-ons to get closer to the cost of providing the care, noting that it won't get there. Medicare, even with those add-ons, is paying approximately 85% of the cost of providing services to our rural areas. So there remains a pretty substantial gap, and making it up with commercial carriers isn't enough. We also really want to have a conversation about reimbursing for no transport. There is a code in there right now, but it's ill-defined. And looking at payment for community paramedicine services, whereby EMS providers are used to take care of patients that don't otherwise qualify for home health services, but looking at programs such as ER avoidance, keeping patients out of the hospital, and ultimately reducing costs of the MaineCare program. So that is a lot of information to throw at you all at once. I did see that nobody interrupted for questions, so maybe I was more clear than I thought I was, but I certainly want to give the opportunity for questions and dialogue, so I will stop there.
Thank you. Questions from the committee for Mr. Kellner? Yes, Representative Craven.
Thank you, Madam Chair. Thank you for the presentation. I would like to know what a non-emergency service is and why does an ambulance provide non-emergency services?
So non-emergency services tend to be those transports from one healthcare facility to another healthcare facility in a non-emergent situation. Sometimes that's from a hospital to a skilled nursing facility. It might be from a hospital, from a lower level of care to a higher level of care. Several services that only do 911 elect not to provide that non-emergency transport because of thin resources, ability to staff, and the need to continue to meet our promise. And that's if somebody calls 911, we'll come and we'll be there, and we haven't missed on that yet, and we don't ever intend to. The larger services are the ones that tend to do the interfacility transport, and that tends to spread out some of those fixed costs.
Senator Claxton.
Thank you for that presentation, Mr. Kellner. Were those recommendations put in order of priority, or was there some other flow?
Yeah, so they're designed to build on each other. So for example, we recognize you can't have recommendation 2 without doing recommendation 1 first, and so on and so forth. The final recommendation for the advisory committee remains the outlier there, and that could be done with or without the other recommendations, but they were designed to build upon each other.
Thank you.
Thank you.
Representative Perry.
Yes, I think I wanted to go a little bit further with the reimbursement in other states. How many states do with Medicaid, rural, super rural adult?
So I think I got there were some audio glitches on my end, but I think the question is what other states in their Medicaid program do the rural and super rural add-ons? We are not aware of other states that are doing that at this point. One of the pieces that we looked at and was recognized when we worked to set the main care rates to the Medicare rates was the geography of Maine tends to be different. So if you look at our neighbors, we do acknowledge that their Medicaid reimbursement is substantially less favorable than that of the state of Maine. Maine has one of the more favorable reimbursements in tying to Medicare. So we were innovative in that sense. The goal, really is again to get closer to the cost of those rural services that, for example, Massachusetts and Connecticut don't necessarily have. They don't have services with those low volumes to cover huge areas. So again, we're simply asking for the match in the methodology. But to answer your question directly, I can't point to other states that have done this. We would love to be innovative and be the first.
Senator Moore.
Thank you, Madam Meyer. And Mr. Kellner, thank you so much for your presentation. I really appreciate that. I'm quite interested in the rural and the super rural. Is there any published, for example, by zip code that would show what would be classified rural and then versus what would be called super rural?
Absolutely, and I'm happy to provide that for the committee. It's a monster of a spreadsheet and it goes by zip code, but we can provide that. It's done by CMS.
Okay, great, thank you.
Senator Claxton. You're on mute, Senator.
Thank you, Madam Chair. I may have missed it, Mr. Kellner, but did you talk about your participation in the rate review that DHHS has ongoing and whether you felt like you were heard?
So I think the rate review was good, and I participated with different areas that I represent, including home care, for example. The Maine Ambulance Association generally shared our feelings, and we did a consolidated response. There wasn't a huge opportunity for dialogue around ambulance services, and in the interest of full transparency, we were a bit surprised by the recommendations, and we still, as I mentioned in my remarks, are having trouble understanding exactly what they're meaning or referring to with some of the recommendations. But I thought the work was thorough, and it was certainly interesting.
Thank you.
Seeing no other questions for Mr. Kellner, does the committee have your PowerPoint?
I believe that was circulated.
Okay, thank you. Seeing no other questions, we are grateful that you were here today, and we've got some work to do, and I expect we'll see you back.
I appreciate that very much. Thank you.
So, moving on, we have our first public hearing scheduled for 2 o'clock today. So I am not sure. It is 1:35. I'm not sure who we have. I can take a look at who is here. Anna, did you have?
No, we did advertise them for 2 because we thought that you might want to work on, we thought you may want to have a discussion about ambulances now, but it sounds like you'd rather do that at another time. So yeah, I don't know that you can start at 2 because people will not know that they should be listening.
So I guess I would ask Senator Claxton, go ahead.
unless there's a book report or a bill that we want to look at related to ambulances, we probably ought to wait till 2. And give Representative Javner a chance to introduce herself.
Yes, I was going there next. Both Representative Madigan and Representative Javner have joined us since we did introductions. So Representative Madigan, would you like to introduce yourself?
I think I already did, but I'll do it again.
Oh, I'm sorry. Then we'll go to Kathy. We'll go to Representative Javner. Welcome.
Yeah, go ahead.
Still not unmuted. Now are we unmuted? There we go.
You are
Good
unmuted.
afternoon. It is so good to see you guys. I'm Representative Kathy Javner. I represent House District 141, and which is located in Penobscot and Washington counties. Thank you.
Welcome. It is lovely to see you. So I would suggest that we take a bit of a break and allow our presenters and others to come at 2 o'clock so that we can begin our public hearings. So I will see you at 2. Representative Perry, you received my, yeah.
Yeah, and I responded. And I said, sure.
Thank you, ma'am.
Yeah.
We'll give it another minute.
Senator Moore, Representative Perry, and Representative Javner are all in a line, and they're all from the same area. They have their own row. I don't know how Zoom figured that algorithm out. When I do not understand the algorithm of Zoom, and when I figure it out, because it makes me crazy who somebody talks.
Well,
and
everyone has different, yeah.
I think it's random just to drive us crazy.
Yep.
It's
Well, that's
working.
only if you have OCD.
Welcome back to our virtual horseshoe here at the Joint Standing Committee on Health and Human Services. We are about ready to launch into 4 public hearings. It appears we may have a change of order. I am not seeing the sponsor of 423. Senator Baldacci may be in another committee. And in that case, we will switch up the order and hear 1386 first. Before that, I would just ask that if you are testifying on any of the LDs before us today, please make sure that the name that you signed up to testify with is the one that shows up on your Zoom square, and that in order to help our clerk manage the attendee list, you exit the webinar once you've finished your testimony and answered any questions from the committee, and watch the rest of the hearing live on YouTube. We take testimony in the following order: sponsor and any co-sponsors and other legislators, those providing testimony in favor of the bill, those opposing it, and then finally neither for nor against, but with additional information for the committee. We run a 3-minute clock on testimony, and you'll receive a prompt when you have 30 seconds left asking you to kindly bring your testimony to a close. Public hearings are just that, they are for the public. The process of hearing testimony certainly encourages probing questions from the committee, who is asked to use the raise hand function in order to ask those bill-related questions. We've done our round of introductions, so I would ask that the sponsor of LD 1386, a resolve to improve access to bariatric care, Representative Ann Perry, it's all yours.
Good afternoon, Senator Claxton, Representative Meyer, and fellow members of the Health and Human Services Committee. I'm Ann Perry, and I represent 9 communities in Washington County. I am here today to introduce LD 1386, a resolve to improve access to bariatric care. This resolve requires the Department of Health and Human Services to develop a plan to provide up to 16 new specialized bariatric care nursing facility beds throughout the state to serve individuals who are morbidly obese. This bill, as LD 177, was presented last session and passed and died with inaction because of the pandemic. A morbidly obese person requiring rehabilitation in a nursing facility is presently negotiated 1 patient at a time. However, this is difficult because the facility needs to make changes to equipment such as size of bed, wheelchair, chair, toilet facilities, and at times widening of a doorway. This may also require behavioral health services. The most effective solution is to have some beds designated as bariatric beds with the reimbursement already in place. This streamlines the process and does not become a bottleneck of care for these people. And one example, a small one, I had a patient who was morbidly obese and when mobile required a wide wheelchair and required extra large briefs, which was not on the list acceptable supplies for reimbursement through Medicaid. It took 4 months to go through the process to get these covered. And by that time, the person had built up a $400 debt to the local pharmacy. This is money she did not have. And as she got weaker, she required more assistive equipment to take care of her. She is typical of patients who must be hospitalized because they cannot currently be cared for in a nursing facility. For the sake of this patient and others like her, I ask for your vote ought to pass on LD 1386, a resolve to improve access to bariatric care. Thank you.
Thank you, Representative Perry. Questions for the bill's sponsor from the committee? I am seeing none. I would ask, well, there she is. Representative Jess Fay, welcome.
Thank you, Madam Chair. And thank you for the opportunity to testify in favor of LD 1386. Last session, I actually happened to be sitting in person in the committee room when Representative Perry introduced this bill. And I had approached her afterwards and said, hey, you know, that's really interesting. I actually didn't know that a bariatric bed was a thing, but I have a constituent who just went through a situation, or actually is currently going through a situation that I think that this proposal could help with. So I wanted to just share Sam's story with you. Sam is was a bariatric patient with multiple health issues. He was working remotely at one time and being cared for by his mother and his sister until a health emergency sent him to the hospital. After a long stay, he was discharged to a rehab facility, and after a long stay at the rehab facility, he eventually returned home. It was a challenge for his family to care for him, partly because his family caregivers had their own health issues, also because the apartment that he had occupied in his sister's rambling farmhouse was on the second floor, and he wasn't physically capable of using the stairs. So while he was in rehab, the family renovated a first floor space so that he could remain at home and have his own privacy. He then had a second emergency health issue, and during another long hospital stay, it was determined that he could no longer be cared for at home, as he required full-time assistance with the activities of daily living. He was basically bedbound. Sam stayed in the hospital for almost a month while waiting for a bariatric bed. Finally, they located one for him in Massachusetts. In order for his family and friends to visit, they had to drive 2.5 hours out of state in order to do so. Approximately 6 months later, he was still hoping to access a bed closer to home when COVID-19 happened. He remained in the facility in Massachusetts until they had an outbreak, and he became infected and passed away, and that was just about a year ago. And his sister would have been here to share this story with you, except that she herself is currently hospitalized. So I am here sharing this story with you in hopes that we can find a good solution to help these folks who need specialized care right here in the state of Maine. Thank you for your time.
Thank you, Representative Fay. Any questions from the committee? Seeing none, we appreciate you being here and sharing your constituent story.
Thank you.
Up next is Brenda Gallant. Brenda, welcome. Ms. Gallant? I'm not sure if she has stepped away. do we have Christopher Wellens? We do. Welcome.
Can you folks see and hear me okay?
We can.
Fantastic. Senator Claxton, Representative Meyer, and members of the committee, I'm Dr. Christopher Wellens, Senior Medical Director of Utilization Management at Maine Medical Center and a practicing internist, and I'm here to testify in support of LD 1386. When a bariatric patient is medically cleared for discharge, but continued non-hospital care is necessary, a skilled rehab or long-term care facility cannot accept the patient until specialized equipment has been ordered and received to ensure appropriate care can be provided. Many skilled rehab or long-term care facilities in the state do not currently have this equipment. Facilities need to be sure that their staff are trained in the safe care of bariatric patients and that they are adequately compensated for the increased staffing and equipment required to care for these patients. For these reasons, a bariatric patient is often held in the hospital for weeks or even months until the special equipment has been received and adequate staffing is secured. Since its inception in 2014, Maine Medical Center's Long Stay Intervention Work Group has tracked 57 bariatric patients at Maine Medical Center. Of those, 47 patients weighed more than 350 pounds, and their average length of stay was 57 days, for a combined length of stay of 2,561 days. Over 1,600 of those days were avoidable. If you consider that an average stay on our medical surgical units is a bit over 6 days, then those unavoidable days translate to over 250 Maine residents who could not receive care at Maine Medical Center. This statistic is particularly bothersome, considering the strain on the hospital and its care team members during the pandemic. In 2019, a patient who weighed 500 pounds at admission was admitted to the hospital with a leg infection that required antibiotics and skin grafting. Long-term care was necessary at discharge, and the patient ultimately stayed in the hospital for 527 days while a long-term care bed was arranged. Ultimately, MMC provided funding to an accepting facility to create a bariatric space for his long-term care needs. The legislation before you today will help ensure that bariatric patients are able to move to the appropriate level of care more quickly than they are now and reduce the length of stay in the hospital, which is incredibly costly to both hospitals and the state of Maine. This legislation helps to support the common hospital mantra of the right patient in the right bed at the right time. You will hear testimony from DHHS that discharging bariatric patients from Maine hospitals to skilled nursing facilities is really not a problem, but our data clearly belies that hypothesis. Maine Health would ask the committee to consider amending the bill to ensure that beds serve individuals who are eligible for skilled or long-term care and need bariatric care.
30 seconds, Dr. Wellens.
At Maine Medical Center, we have many patients that could return home after receiving skilled care. Finally, it's critical that patients across the state have the ability to transition from hospital-level care in a timely way, so we request that bariatric beds be distributed throughout the state to ensure patients have access to care regardless of where they reside. For those reasons, I urge the committee to amend the legislation to include skilled care and vote ought to pass on LD 1386. Thank you, and I'd be happy to answer any questions you might have.
Thank you. Questions for Dr. Wellens from the committee? Seeing none, we thank you for being here today. I'm sorry, Senator Claxton.
Sorry, I was slow to the switch. Dr. Wellens, I'm curious about where the 16 comes from and whether you have statewide data that would make that number 16 or 12 or 20.
You know, I honestly do not know where that number came from, Senator.
Okay. I just wanted to make sure. And you think that having arbitrarily 4 beds in the Cumberland County area would take care of bariatric nursing facility needs?
I do. We have 2 patients at Maine Med right now that need these services.
Okay. Thank you for that.
Seeing no other questions for Dr. Wellens, I would ask if, actually we'll go back to Brenda Galland. Brenda, are you here with us? You are. You're muted.
Gosh, I'm so sorry. Can you see me?
We can see you and hear you.
Good.
Welcome.
Great. I can only see you. So I'm sorry for that glitch earlier. So good afternoon, Senator Claxton, Representative Meyer, committee members. My name is Brenda Gallant. I'm the long-term care ombudsman. We wholeheartedly support this bill. Over the years, we've worked with a number of individuals, both with bariatric needs, both in the community and with patients in hospitals. And our experience has been that it takes months often to find a nursing facility that will admit these patients and individuals in the community. And we think there's a great need for the development of these beds in nursing facilities. As you know, the Ombudsman program works with patients in hospitals. We get an average of 200 referrals a year. In 2020, we assisted 200 hospitalized patients that experienced barriers in accessing long-term services and supports when they were ready for discharge. And of those 200 referrals, 12 of those patients were waiting in hospital beds because of their bariatric needs. It really, what we have found through our extensive experience is that it takes months often to find a facility that will first agree to consider the patient. And then, as was described by Representative Perry, to really do the planning, get the bariatric equipment, the lifts, the bed, widening door openings, also looking at staffing patterns because they may have to hire additional staff, finding a private room, getting prior authorization for medical equipment, transportation. And then typically what happens is that the facility will determine what their costs will be for providing this care. And then they work with the department who reviews the request for reimbursement, and then the admission is possible. So this is such a lengthy process that it's really difficult keeping people in the hospital for that length of time and people in the community who may be at risk. In my testimony, I shared with you some information about an individual that was in the community that I worked with for over a year, trying to help him get admission to a nursing facility. It was a very difficult situation because staffing was inadequate. His doctor was calling me almost every day saying, you know, we really have to do something. I called all the New England states. I called as far as Ohio, trying to find placement for him. And eventually he was admitted to the hospital where they did a tremendous job in terms of helping him with weight loss. And then we found a facility that did the renovations, found the staffing, and did an excellent job. So in our experience, it really makes a lot of sense to develop these resources in facilities here within the state so that people can have access to them both from the community and from the hospital. And with respect to Senator Claxton's question earlier about the number of beds, that was something that we just kind of guessed about in the beginning, to think maybe 16 would be really a sufficient number of beds. And I do think that would make, even half that would make a significant difference. Thank you.
Thank you, Ms. Gallant. Questions? Yes, Senator Claxton. You're on mute, Senator.
I know. Thank you, Madam Chair. So, Ms. Gallant, thank you for clarifying where the 16 came from. My question relates to a reasonable lead time to develop the rules and the bundle, and an appreciation from the department for how much this should be how much it costs, and what reimbursement should be. Do you have a time frame for that kind of work?
Well, you know, in looking at Representative Perry's bill, I mean, I think she has a pretty good, the plan looks very good in terms of reaching out to do an RFI to see which corporations might be interested in doing this care. I mean, I think that with respect to this bill, it's got good timelines in terms of the outreach and getting a response. I think it's reasonable.
And follow-up question? Thank
Sure.
you. And in terms of a rollout, all 16 wouldn't be coming online on the same day. We could talk about building towards 16 or a sufficient number. understanding that they'd be coming in ones and twos.
Well, I think that's certainly what really would be up to which providers are interested, what they thought they could do. And certainly, even if we just had 8 beds to begin with, or, 10, or, but I think up to 16 would be a good number. And as I said, there's just a really pressing need. People shouldn't wait months in a hospital, or it's not the right use of that resource, and people in the community are at risk.
Thank you.
Thank you. Ms. Gallant, were you intending to provide testimony in support of LD 423 as well today?
Yes, and it would be essentially the same.
It would be essentially
Yeah.
the same. So I'll ask that of the rest of our testimony today. Thank you very much.
Thank you, and I'm sorry for the technical problems.
No apology necessary. We have plenty of folks in line to give testimony, and they took your spot.
Thanks.
Next up is Jeff Austin. Jeff.
Representative Meyer, Senator Claxton, members of the committee, my name is Jeff Austin. I'm here on behalf of the Maine Hospital Association to speak in favor of the bill. You have my written testimony. I would characterize it as somewhat puffery. Let me try and be rather blunt on the issue. This is kind of similar to the emergency room issue you had yesterday and residential care facilities and the challenge of getting those patients into those facilities. In each case, what you heard from DHHS yesterday and what you're going to hear again today is they're aware of the issue. Their manual can accommodate this issue. That is, they recognize that they can negotiate an additional rate and provide resources, and they have staff ready and willing to do that. The problem with that testimony is that it is highly inefficient. And it's inefficient because I think it ignores a central problem. These facilities don't want these folks. They're not calling DHHS for accommodations to put in these beds, to make structural changes to their facilities, because they don't want them. They present risk of injury to their staff. You have problems with your star ratings because you have a lot of complications with these folks. You may need specialized nutrition services, counseling services. They're challenging. They're tough cases, just like violent cases in residential care facilities. It simply is not going to work to say our manual and our staff are ready to get the call. Our staff and Brenda Gallant's staff beg and plead and prod with facilities to take these cases on. So it just doesn't work or work efficiently. We believe it is just much smarter to design a facility where the staff knows what they're signing up for, the care is specialized, they're ready to provide it, they know that's what they're going to provide, they're getting equipment that accommodates these folks. It does not make sense. By analogy, we have a statewide need for inpatient psychiatric bed services. That doesn't mean every hospital should be calling up and negotiating with DHHS for each psych patient. It makes so much more sense to have a few units scattered across the state where they provide that specialized care. So I think the department is aware of this issue. I don't think this is simply a matter of, boy, we just need to let the long-term care facilities know that they can call and get this rate. That's not the barrier. All the challenges that go along with treating these specialized folks is the barrier. And it's not going to be overcome easily. Our social workers can testify to it, and so can and does Brenda Gallant. So we want to,
Mr. Austin.
We want to tackle this in a more efficient way. The fiscal note really shouldn't be a big issue because they do pay for these folks today. It's really only the RFP organizational effort. But given all the administrative effort they're going to save down the road and not negotiating these things one off and one off and one off, I think there's potential long-term savings for the administration if they will do the upfront work of negotiating an RFI with a provider. I think when we talked about this, Representative Perry, a couple of years ago, there were some long-term care providers that said, if we could sit down with the department and hammer out a number, we're in a position to seriously consider running one of these facilities. And I think that's a real possibility again. So with that, I'll wrap up and take any questions, but that's kind of our issue here.
Thank you, Mr. Austin. Senator Claxton, did you have a question for Jeff Austin?
I do. Given the what you just said, are you talking about a freestanding unit, or are you talking about designated space adjoining or designated within a wing of an existing facility?
Great question. That's something we talked about before, and that's kind of what the RFI, RFP would tease out. I don't know that there's a right answer or a wrong answer. There may be a facility that has a wing that someone wants to convert, or someone might do a full conversion or a freestanding. I would leave that to the experts in the department to hammer that out, but the RFI would tease that out. Could go either way.
Oh, thank you.
Any other questions from the committee? Seeing none, Jeff, your testimony on 1386 would also apply to 423?
Yeah, we've worked with Representative Perry on this for a number of years, and so I have a more confident background on that one than I do the other one, but yes, similarly supportive. Thank you.
Thank you. Up next, Rick Erb.
Thank you.
Mr. Erb, welcome.
Good afternoon, Representative. Senator Claxton, members of the committee. My name is Rick Erb, and I'm the president and CEO of Maine Healthcare Association. We represent the majority of Maine's nursing homes, and I want to testify today in support of LD 1386 and thank Representative Perry. Maine nursing homes are required to only admit residents that they can safely care for, and this can be challenging when the resident needs complex and expensive. Bariatric care requires specialized equipment like beds, lifts, grab bars, additional staffing, special training, often in behavioral health, and may require extensive environmental and dietary modifications at the facility. In some cases, providers may have to convert semi-private rooms to private rooms in order to accommodate residents. We are pleased that the proposal acknowledges these expenses and calls for appropriate reimbursement to provide this level of care. The state has been willing to pay additional amounts for out-of-state care when special services are needed. Historically, though, DHHS has expected in-state facilities to provide services for their normal rate or provide a temporary higher rate that is slashed when the state budget gets tight. Today, the average Maine nursing home operates with a negative margin and can't afford to take a loss on bariatric care or any other specialized care. In the absence of special units, normally recognized beds, we've been pleased to see the providers work with DHHS and the Long-Term Care Ombudsman on a case-by-case basis to provide quality bariatric care. I applaud my members who have stepped up to accept these challenges. I appreciate that the resolve sets a goal of 16 beds, but gives flexibility in terms of the location of the beds. It will be important to consider the demand for services and the individual nursing home's ability to provide the services in any community. I also appreciate that the bill set deadlines for accomplishing this work, parameters that will keep the state on pace to provide these specialized services for Mainers who need them. Other states have had special units with corresponding reimbursement rates to sustain them for years. Examples include bariatric care, ventilator units, dialysis, to name a few. For those limited instances where special units are needed, they have been effective. Maine has not totally embraced this strategy, but as we see our long-term care residents changing, we need to be responsive to their needs while ensuring we stay viable with sufficient Maine care rates. Having the right tools, additional staff who are trained to work with bariatric residents, and just the opportunity to have a private room can make all the difference in the life of the resident. My members welcome the opportunity to be part of the discussion and solution. LD 1386 addresses this issue in a responsible manner and we're pleased to support it. Thank you very much. The only thing I would add to that is to say, in my time here, the number of requests for these services has increased dramatically, and the weight that we are dealing with has also grown. The number of people who I would say are extreme bariatric patients has increased substantially over what I can remember from 15 or 20 years ago. They become a real issue, and I'm hoping that this bill would address that. Thank you.
Thank you, Rick. Questions for Mr. Erb from the committee? Seeing none, we welcome Lisa Harvey McPherson.
Could I just add
Of course.
on the other bill?
Oh, yes, I'm sorry.
That's okay. My plan on that was to say that we had detailed comments for the bill you've just heard. We support the other as well, but I would not have anything different to say.
Thank you, Rick.
Yep, thank you.
Welcome, Ms. Harvey McPherson.
Thank you, Senator Claxton, Representative Meyer, and committee members. My name is Lisa Harvey McPherson, and I'm here to speak in support of this bill. I support everything that you have heard so far, and I want to remind the committee, this bill represents a unanimous agreement of the Health and Human Services Committee to address this fundamentally flawed process for bariatric patients. I think what would add value to the discussion is if I walk you through the process that we agreed to in developing bariatric beds in nursing facilities in Maine. We envisioned a process, and in this bill, it would start no later than August 31st. The department would issue a request for information for nursing facilities to respond to their interest in a bariatric bed. We envision 4 units across the state of 4 beds to get to 16 beds, but that doesn't mean that's where the provider community is. We also need an RFI because this could mean substantial new construction, or it could mean substantial renovation as facilities need to brace the floors. They need to redesign these units. They need to redesign bathrooms. Everything needs construction. So once we have that interest, then no later than October, the department will review the request for information and determine here is the need, and then initiate a rulemaking process to establish a rate to reimburse for those beds. And that rate would be a fee paid to the nursing facility. But we also understood in Maine Care policy, the department was interested in having the nursing homes bill directly for durable medical equipment, transportation, which is specialized emergency transport, and behavioral health services. So all of that would be worked on no later than December of this year. Then in March of next year, the department would issue a request for proposals. They would award the contracts in June, and in September of next year, the providers must have those bariatric beds available to the community. And Senator Claxton is right, we can phase that in. But this is what we envision to meet all of the kind of moving parts of how do we do this to improve this process to get to the goal of having bariatric beds in our nursing facilities. So I thought it would be helpful to walk you through what we envisioned in this bill.
Thank you. Questions for Ms. Harvey McPherson? Seeing none.
Thank you.
That concludes the testimony on 1386. Requests for additional information from the committee. Seeing none, I will close the hearing on LD 1386. Open the hearing on LD 423. In the absence of the bill's sponsor, I will turn to Senator Claxton.
Out of respect for the folks who've come to testify on both these bariatric bills, I volunteered to read a colleague's bill. This relates to LD 423, which is an act to improve access to bariatric care in nursing homes. The lines provided in the bill say that the department shall provide specialty bariatric care centers embedded in nursing facilities to provide requisite care within the nursing facility setting. The summary from the department reads much the same. From OPLA, this bill requires the Department of Health and Human Services to provide bariatric care centers embedded in nursing facilities to provide requisite care within the nursing facility setting. And I would interpret that as a concept draft.
Thank you, Senator. We have no one signed up to provide testimony specifically on 423, and we did hear from those providing testimony on 1386 that their testimony would have been the same. So I would ask the committee if they have any questions for our analyst on 423, and if not, I'll close the hearing and we'll move on. Closing the hearing on LD 423. Thank you, Senator. Opening the hearing on LD 1325, an act to provide relief from audit requirements for certain healthcare facilities during a state of emergency.
Have I been, this is Joe Perry, have I been called on? I was muted for a bit.
You are Representative Perry. You're up if you'd like to deliver your testimony.
Yes, thank you so much, Madam Chair and Senator, members of the committee. I'm pleased to present this bill today. I have to tell you, I'm driving on I-95 as I present this. This bill got kind of put on the back burner, and I did not have it on my calendar for today, so it became a surprise that I had to present this afternoon. But it's just one of those bills where I think we potentially have an opportunity to relieve some stress for some people here in the state of Maine, some hospitals potentially. I'll tell you how it came about. We had a meeting last winter with St. Joe's Healthcare, and just general issues were coming up. And one of them was they weren't going to meet their bond requirements through MAHIFA, their covenant, and not that they couldn't make the payments, but their ratio of income to debt service was out of line. And when that happens, they have to do a very extensive process, hire out auditors, and spend between $100,000 and $200,000 in auditing costs to make sure everyone knows what the issue is, why the numbers are out of whack. Well, there was no question why they were out of line this year. It was because of COVID. And since I sponsored this bill, St. Joe's Hospital did get $5 million in federal funds, so they do not have to go through this process. I did not withdraw the bill because my understanding is there could be other hospitals in the same situation where they're not meeting the full agreement of the MAHIFA bonds, but the reason is not in question. And if there's anyone out there that we could potentially save the time and expense of a very expensive audit for this 1 year or maybe a 2-year period, it might be worth a try. So I don't know if there's enough there to go on. If the committee has any interest, I'd be certainly happy to try and do work on it between now and the work session, but that's where it stands at this moment.
Thank you, Representative Perry. Questions from the committee on for Representative Perry, the bill sponsor? I am seeing none, so thank you for being here, for calling in. Be careful driving if that's what's happening. And we have no one signed up to provide testimony on LD 1325. So I would ask the committee if they've got any questions or requests for information for our analyst. Senator Moore, are you speaking? No.
Well, I was just reviewing the one written testimony that was, and I was just commenting, oh my goodness, okay.
Okay. Thank you. Seeing no requests for additional info, Representative Javner.
Thank you very much, Madam Chair. If one of the analysts could find us the information about how this has been impacting the other hospitals, or if there has been any other impact for any other facilities, that would be great to know. Thank you.
Thank you very much. I will close the hearing on LD 1325 And because I know you're all very flexible as we play musical chairs, the next bill is one I am to introduce for the department. So I will hand the chair over to Senator Claxton.
Thank you, Madam Chair. And now you can go ahead and introduce LD 1344.
Thank you very much. Good afternoon, Senator Claxton and esteemed colleagues on HHS. I am Representative Michelle Meyer, serving House District 2 in Southern Maine, Elliott, and parts of South Berwick and Kittery. I was asked to sponsor this bill, LD 1344, an act to clarify the authority of the Department of Health and Human Services during a public health emergency at the request of the department. LD 1344 addresses administrative and licensure violations during public health emergencies. And I am very happy at this point to turn this over to Ms. Sarah Gagne-Holmes to provide additional information to the committee on LD 1344.
Thank you very much. Good afternoon, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Sarah Gagne-Holmes. I'm a Deputy Commissioner at the Department of Health and Human Services, and I'm here today to help introduce and speak in support of LD 1344. LD 1344 would provide the department with additional tools to address imminent public health hazards in order to control infectious disease outbreaks and protect the health and safety of the people of Maine. These tools include administrative fines and license suspensions for violations of department rules regarding disease control during public health emergencies. Additionally, the department is authorized in the proposed language to establish procedures specific to the closure of any licensed business or entity when that business or entity directly and repeatedly violates public health control measures during an extreme public health emergency. All Maine businesses must operate in accordance with laws established to protect public health, whether those laws are established through executive order, during a public health emergency, or through the legislative process. It is the role of the licensing agency to ensure that businesses under their regulatory purview are operating in accordance with the law. This bill strengthens the department's ability to respond timely and appropriately to enforce orders issued during a health emergency. During the COVID-19 pandemic, the governor's executive orders provided the department with authority to enforce the orders and the COVID-19 prevention checklist, which detailed best practices for safely operating businesses, including, but not limited to, staff stay home when sick, wearing cloth face coverings, physical distancing, etc. This authority enhanced and supported the health inspection program's existing authority to take licensing action for observed health and safety hazards under 5 MRS section 10004 subsection 3. The HIP health inspection program interpreted non-compliance with executive orders and COVID-19 prevention checklists as an imminent health hazard under its own statute and rule, and implemented appropriate licensing actions for the protection of public health and safety during this extreme public health emergency. In response to reports of non-compliance, HIP followed up on complaints and provided licensees, such as restaurants, lodging places, campgrounds, etc., with education on the related orders and COVID-19 prevention checklists. Education was always the first step that the department took. When non-compliance was observed after providing education, HIP issued an imminent health hazard finding. Continued observed non-compliance resulted in a temporary suspension of a license for up to 30 days in accordance with Title 22 MRS Section 2500 and 5 MRS Section 10004 subsection 3. And if a licensee continued to operate after the license suspension, penalties were assessed daily for operating without a valid license in accordance with 22 MRS Section 2498. From May 2020 to present, HIP has issued 23 temporary suspensions and 93 imminent health hazards for non-compliance and has assessed fines against 6 establishments for operating while their license was under suspension. Currently, 22 MRS Section 2498 permits the department to impose fines up to $100 daily for a licensee's initial and continued non-compliance. Additionally, section 2498 subsection C specifies that an unlicensed establishment, which includes those with suspended licenses, may be subject to fines from $25 to $500 per day per violation. These fines permitted by section 2498, however, have not deterred some businesses from operating in direct and repeated violation. In one instance, an eating establishment operated continuously during the 5 periods of temporary suspension of license. It was only when the court imposed a contempt of court finding and a $5,000 per day fine for additional operation that the licensing establishment closed its business. A more impactful penalty is needed to enforce cease and desist orders and to ensure that businesses operate in a way that protect the health of their staff, their customers, and that does not jeopardize public health in Maine during a public health emergency. LD 1344 will provide the department additional authority to impose more consequential fines and or force the immediate closure of a business that repeatedly violates public health control measures during an extreme public health emergency, an enforcement measure critical for protecting public health. This bill also allows a licensing agency to directly and temporarily suspend licenses for more than 30 days. Currently, a maximum of 30 days is permitted under Title V, Section 1004, subsection 3, for temporarily suspending licenses. During the pandemic, 6 HIP licensees operated after their licenses were suspended. 4 of these licensees had temporary suspensions reissued for up to another 30 days due to continued noncompliance. This bill will only impact those businesses that fail to obey an order and repeatedly violate public health measures in an extreme public health emergency. Importantly, if the proposed language regarding license suspensions is enacted, then the district court, at the licensee's request, would review any temporary suspensions of licenses during public health emergencies resulting from violations of public health control measures. This judicial review would afford licensees the ability to challenge a licensing agency's decision to temporarily suspend licenses for operating in a way that poses an imminent risk to public health or safety. In summary, the department recommends this bill ought to pass to provide the licensing agency authority to protect the public during a public health emergency by providing the ability to impose significantly greater fines, revoke, suspend, or refuse to renew a license beyond 30 days when there is imminent risk to public health or safety, and close businesses for repeated and continued noncompliance. LD 1344 seeks additional authority to enforce laws necessary to ensure the public health and safety of Maine people. However, it also limits that authority to public health emergencies by amending Chapter 250 of Title 22 rather than Chapter 562 of the HIP program. Thank you for your consideration of this matter and for the opportunity to provide testimony today. I would be happy to address any questions from the committee, and I and my colleagues will be available to participate in the work session. Thank you.
Thank you, Ms. Gagné-Holmes. Are there any questions about this testimony? Representative Javner?
Thank you very much, Chair Claxton. Yes, thank you, Deputy Commissioner, for being here. Is your testimony going to be available online for us? I did refresh my page. I don't see it on there.
Yes, I believe that my colleague Molly Bogart was going to provide it.
Perfect. And if I have Chair, I have a follow-up.
Please.
Thank you. So can you just on Mike here define what the extreme public health emergency definition is?
I can, let me just pull it up. I would also indicate that only the governor can declare an extreme public health emergency, usually in conjunction with 37B powers. But I do have the definition right here. Extreme public health emergency, which is in Title 22, Section 801. Extreme public health emergency means the occurrence of imminent threat of widespread exposure to a highly infectious or toxic agent that poses an imminent threat of substantial harm to the population of the state.
Thank you.
Are there any other questions of this testimony? I don't see any. My question was, this is quite similar to a bill we considered earlier in the session and haven't come back to, that imposed the fines up to the $5,000 level. I understand that's being rewritten. That too is a departmental bill. We might be looking at an opportunity to roll the two bills together if it's around the same issue. It was also the public health inspection related.
So the one point of clarification that I would make is that this would change the provisions of Chapter 250, which is a separate chapter than the public health provisions. I don't know if that makes a difference in your consideration, but I did want to point that out.
We've got people who can make that happen. We can work with Ms. Brahm if we decide to go down that path. Thank you very much. Are there any other questions? I don't see any, so thank you for being here and presenting this.
Thank you for the opportunity.
Next, we'll go to Nick Murray, who's here to testify against LD 1344. Welcome, Mr. Murray. If you want to unmute and join us. Afternoon.
Good afternoon. Senator Claxton, Representative Meyer, and the distinguished members of the Committee on Health and Human Services. My name is Nick Murray. I serve as policy analyst for Maine Policy Institute. We're a nonpartisan nonprofit that advocates for individual liberty and economic freedom in Maine. Thank you for the opportunity to testify today on LD 1344, a bill that would dramatically expand executive branch power and degrade the liberty of Maine people. LD 1344 would codify authority for DHHS to fine, suspend licenses of, and ultimately close down businesses if they directly and repeatedly violate public health control measures during a declared emergency. This punishment would be exempt from the hearing process under the Maine Administrative Procedure Act, and Section 7 of the bill would go even further to exempt license suspensions from the normal 30-day maximum currently outlined in statute. Licensees would be able to request that the district court hear their appeal, but the bill specifies that each suspension remains in effect pending the district court's review. Essentially, a business owner who challenges the department's rules would be guilty until proven innocent. The state could twist arms, shutting down a family's source of income while they must plead their case in court. Until last year, most of us had never contemplated a 14-month-long emergency. Public health policy, like scientific understanding, can shift significantly over time. It should be held to the same standard of accountability that we demand of public servants, even in an extended emergency situation. Just in the last year, we've seen the goals of public health evolve like the virus that is targeted. Over the long months, we've been told by Governor Mills, Dr. Shaw, Commissioner Lambrew, and the other administration officials that the broad restrictions on business capacity, gatherings, schools, travel, etc., must continue until we flatten the curve, until we can keep case counts low, until a vaccine is widely available, then until vaccination is widespread, and now until the variants are under control in the state, in the region, in the nation, across the globe even. In 2007, Dr. Donald A. Henderson, former director of the World Health Organization effort, which eradicated smallpox in the 1970s, co-authored a paper in response to a recent CDC plan to institute this type of experimental pandemic response, initially called early targeted layered use of non-pharmaceutical interventions. In that present document, Henderson and his colleagues vigorously cite decades of disease mitigation precedent, which condemn the coercion-based public health philosophy that leads to closed schools, mandatory
30
mask,
seconds, Mr. Murray.
general shutdown of society. The question becomes, I know I'll wrap up. I would urge you to read this paper. It's cited in my testimony. But to wrap up, I think the big question here is, if DHHS has this power and has used this power through the last 14 months during the civil state of emergency, why does it need to be codified in statute? What more would this bill add to law? Both DHHS and the governor have the authority to declare a health emergency under Title 22, Section 802, and enforce those rules that they promulgate. These rules receive little public input, and they can't be specifically amended or rescinded by the legislature. I think this bill is unnecessary at best. At worst, it's a large power grab. Please designate this bill ought not to pass and show your compassion for the thousands of Mainers still struggling to make ends meet in the midst of persistent current restrictions. Thank you for your time and consideration.
Thank you, Mr. Murray. Are there any questions for this testimony? I don't see any. Thank you for bringing your concerns. Next, we'll go to Mr. Merletti.
I'm trying to unmute here. Okay, here we go. Boy, I could say ditto to Mr. Murray. My name is Philip Merletti. I am the spokesperson to Take America Back, and I'm also a co-contributor to the Constitution Coalition. I want to deem this whole bill as not only unconstitutional, but anti-constitutional. I'm here today to declare, and I was only told about this just a day ago, I'm here to declare the fact that when the governor first declared that this was beyond local control, that was done under false information. There wasn't any part of Maine that was out of context or complex with the dangers of a virus. So what I'm saying right now is what this does is it allows the governor to continue her tyrannical powers of shutting down businesses. People lose their homes, their businesses, their cars, their boats, every possession they own, because the governor has falsely declared that this is an emergency. There's no doubt in anybody's mind that the virus is dangerous. But what this does is it continues along with the power that the governor has, and we cannot give the governor any more powers. There's already in the works to change Section 741, Section 742, and Section 43 of the Title 37B. So what I would ask you people to do is to look up, and I know you haven't done this, this is what you need to be studying. Only the legislature can make laws. Only the legislature can change regulations. The governor has changed regulations after the legislature has shut down. She has shut businesses down by creating new regulations, and she is in violation. All this does is it continues to allow her to do this under this bill. I'll be more than glad to answer any questions you have.
I didn't see yet, sir. Did you submit your testimony for?
No, I didn't. I just got information on this just a day ago.
So at your
What I
convenience?
could do is I could submit a whole 80 pages worth of impeachment regulations.
Well, I think probably we're more likely to read the 1 or 2 page version, not the 80-page version, as we try and wade through these. So if you have a shorter bullet pointed, that would be helpful. Are there any questions, Mr. Merletti?
Please ask me now, because this is the only time you're going to hear an honest answer. Nobody needs to hear an honest answer. Okay. This is typical. I've been doing this for 40 years, and the corruption that's in the Maine legislature is amazing.
In the absence of any questions, well, thank you for being here. And I don't see anybody else who wants to testify. So we'll close the public hearing portion on 1344 and see if there's any questions that we want to direct to our analyst. I don't see any for right now. Yes, Representative Javner.
Thank you very much, Senator Claxton. If we could get information, and I think this is out there somewhere, I'm not sure where to find it though, of the number of businesses. I know that the person that testified from the department gave us the businesses that had been had violations against them, but I'm looking for the business numbers, the number of businesses that have actually closed during this 12-month period. If we could have that for the work session, that would be very helpful. Thank you.
Are there any other questions to go to Anna? And I don't see any. So that will conclude our consideration of the 4 bills this afternoon. any other business to attend to at this point?
If I'd known you'd be so quick, I'd have scheduled 20 bills.
We aren't usually this fortunate. So, and we had a couple bills combined, so don't get too ambitious for us. So I don't see any other business to conduct. A relatively earlier day is welcome, especially one with the sun out and it's reasonable out there. So you all be safe. I'll entertain a motion to adjourn until 10 o'clock on Thursday.
So moved.
We adjourn.
Second.
All those in favor?